say very warm welcome to Sam and Sharon. Lovely to have you with us for the optometry centre. Now, we need to speed up because the university is putting on a tour of discrimination for us between 4:15 and 5. So we need to just prompt people with the item. We take every paper out today and really ask the substantive item of the company around the position we actually go to take. Okay? So, Marie, shall I turn to you now then to speak to?
Absolutely, and very, very comfortable time, and it is a long report. With apologies that there are also a couple of appendices that have made it into the main body of the paper, which has extended the read as well. So if you can ignore those, it is still quite a long report. But we'll aim to get it a bit more focused for next time because I think there's a lot of information in there. But I'm going to take it as read. It covers a lot, and I am happy to take any questions from independent members.
And there are things that you want the board to agree.
There are. Yeah. So shall I just walk us through that? So we are requesting from, so there's acknowledging what we're doing in the planning arena, both from a strategic and a medium term time horizon. So it was just asking the board to acknowledge and to consider the progress that's being made under the area plan through the RPB programme. With the PSBs, we are asking colleagues to agree that we continue to work closely on the programmes of strategic work that we are doing with the PSBs. And then in commissioning, we are asking for, so I think the policies for IPR and IPFR have already been formally through the Quality and Safety Committee. So we are asking board to consider the partnership arrangements that we are working with the APB to reduce risk for our citizens, and to endorse the national framework for younger adults that we have adopted through our partnership working, and to receive the All Wales revised policies for prior approval and individual patient funding requests. So those were the three in there. And then finally, and ultimately, to be aware that we are developing an adaptation strategy for the Health Board, and to ask the board to endorse Swansea PSB's climate change strategy, for which we have had close engagement as a Health Board and as a PSB member. And then finally, we have a number of appendices, 7 to 12, under the emergency planning heading, and we are asking for approval for the updated emergency response procedures. So those are the major incident plans, the major incident procedures that we have to update each year and bring through board. So that's the only one formally for approval. The others four are for agreeing and considering.
So I'm going to take at the centre paper as read and operate on an exception basis. Is there any one of those items for agreement or approval that people are not content? Okay. So I will take that as being content, and therefore all the agreements and approvals go through as set out in the paper. Thank you. We promised with it in January. We will spend more time.
You don't need to, I'm very happy
and partnership.
Janet, can I just, having said I agree with you, could I just ask two questions, please? A rise in scan reports. You mentioned them, but I have no idea where I find them.
Okay.
That's the first one. And then the second one is individual patient commissioning. You talk about work streams being underpinned by ambitious plans.
Yeah.
And the delivery is by the end of March 25.
So that, yeah, so it's the approach that we're trying to agree by the end of March 25. The delivery will be over the next year and probably beyond the CHC, because this is a big programme of work.
So the delivery was agreed by the end of March.
Yeah, what we're trying to achieve. Yeah.
Okay. And then my last question.
I've forgotten your first one. What was your first one?
Horizon scan.
So horizon scanning, so those are supplementary summary papers that we're including as a part of the information pack to support the strategic clinical service planning process. They're referred to in here, we haven't actually included them because there's a lot in there, but if you would like to see them, we can share them with you.
Just ask one question, I don't know. Then you mentioned given our work on mental health and learning disabilities and the discussions around the national framework, the national framework agreement for younger adults. And the fact that we've signed up to the refreshed framework from April 26.
Yeah.
There is in there mention of an annual value of 5 million plus.
Yeah, so this is
Is
new,
that accounted for?
yeah, so it's not new money, it's just a new way of commissioning that. That's the National Care Homes Framework, Abby, that we can do with JCT. Sorry,
Oh, that's right.
yeah, so that's all gone through due governance process. We have brought it through management board, and it's been a national decision that we have been part to be involved in.
We're a minute third point. If anyone wants to follow delivery on any specific aspect, happy to make it line. Yeah, I shall. So I am going to suggest another change to our order, so that we don't keep Sharon and Sam with us for an audience of time while we go through the money. Would you like to move to 4-7 now? And Deb, I know you're going to make a short introduction and then hand over to Sharon and Sam.
That's really helpful. Thank you, Chair. Board requested an update on our optometry services. Sharon and Sam have put together a very comprehensive paper to outline the offer we have for the population, and I think it's a really impressive paper as well. I'll hand over to Sharon and to Sam to bring it to life. Both take it as read, don't go into too much detail, and then we can take some questions on that as required, Chair.
Thank you. And if you really can't say, so it doesn't bring too much to us, but our population, so we understand what our population has in terms of optometry.
Okay, so I'll do a brief introduction, conscious of time. So this is the fourth paper you have now, the final set, as it were, of primary care contracts. And this is about our primary care optometry services. And in common with the other 3 papers, there is a major reform going on in this area. And the strategic thrust of that reform is actually to move services from hospital care into the community where it's clinically safe and appropriate to do so. So it's all about upskilling our community optometrists to take on new clinical pathways and roles than they have done previously. So it's quite an exciting time, but it's very new for us and new for us as a team as well. So we've had quite a lot to get our heads around. So we have 32 community optometry practices at the moment and 6 domiciliary providers that provide services across the whole of the Swansea Bay area on that domiciliary basis. The Health Board then, we are obliged to bring in what is called a WGOS framework, so Welsh General Ophthalmic Services, and that goes from levels 1 to levels 5. Levels 1 and 2 are mandatory and were with us previously, although they've had some changes, so that's sight tests and acute eye care. Level 3 is optional, and that's our low vision services, and we currently have a number of practices providing that, which is 15 across the Health Board area. And then WGOS 4 has been the very new area where clinical pathways are being brought in, and at the moment that's for medical retina and glaucoma, but we hope to bring in more pathways early in 2026. And we have 11 practices providing that, and that's very, very new and a growing area. Level 5 then, you'll be familiar from other contractors, is bringing independent prescribing into community optometry. And we have gone from 1 independent prescriber, who's doing a very good job, to 14 now in 11 practices in quite a short space of time. Your paper does include an annex which gives you the cluster provision. We know we're not where we want to be yet, but it is still early days to embed this whole reform. And we're particularly conscious of the Avon and Upper Valley clusters and are prioritising work to upskill the community opticians and to encourage them as well to take on these new services. We work very closely in an eye care collaborative, and that has also had a regional dimension since September. So finally, coming to the end, we have 3.5 million, which is about £8.71 for every registered member of the population. The additional funding for this was provided by Welsh Government, so we didn't have to take it from other areas. So that will help to free up hospital appointments and reduce that pressure. And then on a final note, I just want to recognise that our optometry advisor, Raf Islam, has been nominated for an Optometry Wales Award, which takes place on the 27th, so that's later this week. And he's been nominated in the category of health board support. So I think we can all be proud of that. Thank you.
So just add one more bit to that. It wasn't in the paper, Chair, but I think it's worth noting. Sharon mentioned there that we're working in a regional collaborative now. I think it's fair to say when we look at the two health boards, the difference in the community offer, particularly in optometry, relates to the stability of the hospital services. So Hywel Dda have done much more in the community side of the service with a very unstable medical model in Hywel Dda. We've always had, for a long time, a very stable medical model in Swansea Bay, and therefore we've been slower to develop the community optometry offer. We're catching up now, and we're sharing that learning from what Hywel Dda have done to improve their offer and working together as a collaborative. So the regional eye care work, I think, is going to be really exciting for both regions going forward.
So was there anything you wanted to add? Because we always think the population health lens, and as Sharon has said, because we don't have that equity, to add to that. Well, definitely, I think a lot of it is in the population involved. We need to make them aware of the importance of the aspects, but certainly having access is very important. And we're working closely with primary care on that. That's making meetings now with Sharon.
Chair, thank you very much. It was a brilliant report. It's really great to see. My question is, how are you going to communicate with the public so they know how to access this service, please?
Okay, so there's two aspects, if I might, and I don't know if Sam would want to add to it, but we've recently had published the All Wales Access and Communication Standards, picking up on some of the discussion we had on community pharmacy last time. So we're actually working now to see what information we can get from all our primary care contractors about how they are communicating in different forms and languages, but with their population. The other aspect that we do is through Richard's team, we have an extremely proactive communications program, and we have just been doing the independent prescribing through optometry and the low vision to get that out onto social media and all those other platforms. So we have a rolling program, a comms plan for primary care with Christy in Richard's team to try and make sure that we're making some of these new services as visible as we can, both on the intranet, but then outwards as well.
My question was pretty much the same, and I think I asked it about the pharmacy as well. It is the harder to reach population, the ones who perhaps aren't on social media and find English more difficult to access, and how we get those so that they don't find themselves coming into hospital because they've got eye problems that could have been dealt with in the community.
A big Sam in, if I may, because she's just been looking at, well, last time we spoke, we hadn't had the All Wales Accessible Communication Standards, and there's quite a bit of depth in them, actually.
Yeah, so we are taking forward a specific action now. So using the Welsh Health Circular, it's very clear in the Welsh Health Circular the expectations on primary care providers in relation to communication, understanding the communication needs of the population that accesses their services. So we are taking forward an action now on how we gain those assurances from our primary care providers on how they ensure that they meet in the communication needs and understanding the communication needs of those that access their services, as well as looking at potential training and development that may be needed. So through the Primary Care Academy, we've asked them to look at potential training and development that we could roll out across primary care also. That sounds great.
Can I just add, Chair, that sort of thank Sharon for acknowledging the role that Christie's playing, in terms of the work that you're doing. I think also if we just cross-reference with the work the engagement team is doing around our outreach work and the other activities with the voluntary sector as well, plus we just double-check that those sort of links are being made out there in the community.
Yeah, I know we work with the voluntary sector around the low vision services and the eye care liaison, so that'd be great, Richard, if we could do that.
Louis, you wanted to come in or not?
I think there's a bit about the Southern Bird community you just heard and how we actually communicate, which was just raised. So I'm not going to raise that point again, but I think it would be helpful for us to get an oversight on the access points in terms of the Southern Bird communities and the equality agenda. There is a point around, there is a lot that is expected in the rollout of the Open Eyes system. Some of it looks really good, but I didn't spot any explicitly productivity or cost-saving ones in terms of what we're expected to get, in terms of cash releasing or cost avoidance benefits from this investment. So I thought it would be helpful just to get an idea of that.
On your first point, of course, we refer all these papers to population. And this paper has gone, the next meeting of the population. So I think your first point around equity in that different section, we'll pick up through the committee. Sam, did you want to go back?
Open Eyes is quite new for us, so we're excited to have it. I'm not sure if any cost-benefit analysis has been done, but I think Deb wants to come in, but the referrals and the patient records being available, we are expecting efficiencies.
Do you want to come in on that point, Kat?
No, I just wanted to ask possibly a very silly question, but when we're talking about community optometry services, are we talking about people like Specsavers?
Mm-hmm.
Okay, because I was wondering whether there was this whole other branch in the NHS. I never come across it. I just
really excited. So it's an electronic patient record. So for us, it's the quality and the safety aspect of having this system in place. It will allow us to make more regionally. It's been in development for a number of years, predates me. So the original business case, I honestly don't know what cost benefits analysis was done for it. The funding didn't come from the health board, but its implementation came centrally. So we haven't put any cost into it. I think there will be savings from efficiencies and productivity as a result of that. No, we'll keep it. I was going to say keep an eye on it then, but I won't. Well, we'll evaluate.
Given that patients who really challenge services and behaviour, for example, somebody with a learning disability may have some difficulty and challenge, how are we meeting the needs of their optometry service, the community-based service? Do we still link into the Cardiff services for specialists?
On that, but just in terms of the learning disabilities, part of the change we've had in our cluster development is to include community optometry in that. And one of the first things we asked them to look at from the regional partnership board priorities was meeting the needs of people with learning disabilities. So I'm really pleased to say the clusters were able to invest in equipment for community optometry that they wouldn't need to have as part of the course of their business normally, specifically to make it easier to do eye tests and things for people with learning disabilities. I think technical equipment's in the paper, but I can't remember it at the moment. With regards to linking to the Cardiff service,
I don't know.
No, we have to check that.
Yeah, so really interesting, thank you. And these services, we don't always see the full perspective of. There's quite a lot of data in your report, which is really helpful. And I'm thinking from a sort of value-based healthcare allocated perspective, is there more that we could do to help all of the key areas within the directive grow and support different balance of care models from across acute? I'm just wondering, I guess the essence of the question is that a way to do it?
Yeah.
If so, can we monitor it? Can we particularly monitor the benefits realization of it?
That's a good idea.
So maybe it's going to take upside on that.
Yeah.
Just on that note, we are really fortunate to have a strong primary care team and we're willing to do the work, do the management work with the clinical teams out there. sometimes the reluctance of moving things into the community is a secondary care reluctance. So I think that's the levers we've got to put on. I think community by design will naturally drive that for us.
Any other questions? No? Can I just ask Karen, do we have any issues with recruitment? How do you find, I know that it's difficult to assess reasons like independent business, etc. But what's it look like across the patch in terms of recruitment?
I'll speak too soon. But we are not experiencing the same sort of sustainability issues as I know some other health boards are in community optometry at the moment. The workforce tool that's being relaunched nationally will be available to us soon, and that will then include community optometry information, which we haven't had access to previously. So we're just waiting for them to relaunch that, but with community optometry. I think this is where the work of our Optom advisor really comes in to support the practices and to encourage them not only to develop but to deal with the sustainability issues. We will also have an escalation framework coming in, which will be for community optometry in the same way that we currently get for GMS practices and for community pharmacy. So it's been extended to dental and Optom. And we're very much working with the Primary Care Academy as well to include our community optometry in any training, education and support. And that includes sometimes dealing with challenging patients, and unfortunately sometimes not just for community optometry, but some of our other primary care colleagues dealing with violence and aggression. And we could be surprised by how much of that they are dealing with. So workforce is an area for us. I think the Teach and Treat Centre is something really positive as well. Again, that's outlined in the paper. And I think we've got 9 people with the training, going through the training at the moment for higher qualifications and skills. But we're not aware of any sustainability issues at the moment.
Can I just add? Workforce development is a real priority. So whilst we may not have the sustainability around the workforce within the practice, actually the development of those Optoms needs to be a real focus if we're going to continue to drive the clinical pathways in primary care, particularly for WGOS4, medical retina, glaucoma. We need to encourage and drive those optometrists to complete those higher qualifications so we can continue to sustain that level of delivery in primary care.
It's fascinating as a and we know that we refer specifically to population health, as I said, to look at fatigue, access, etc. What are we doing now with this rich set of data that we have? And how is it going to feed into the 26-27 plan? Given that cluster plans can come together along with our own. And then how are we going to keep the broad perspective on primary care matters in 26-27? Debbie might want to take that last one away. I'm thinking about that because I think this suite of papers in your presentation, we learned a lot. It's been so instructive, and we were excited on our primary care colleagues and their services in this holistic way until this year. So we don't want to lose sight of that. But how are we going to be feeding this all in then?
I think from my perspective, Chair, we have the right drivers in there. And most outputs are the same. Guilty of justice is over there. Okay? Similar in some ways to mental health, that's over there. And the acute services all will get the lion's share of the attention. I think the presentations we've done to board on these 4 services show the wealth of services that we've got out there and the quality and the demand to deliver in those services out there as well. So I think community by design will drive a different behaviour at all boards because that is going to be a focus. We do sometimes found that the different attention from Welshgov, but I think this is going to be a real useful change of direction for all health boards to ensure that the primary care element of services and the primary contracted bits as well is part of core services of all health boards. So I think we've got the right levers in that now. I think that the role that I'm holding in an interim position at the moment is pivotal to that. We have to make sure we are engaging and bringing them in and making them feel very loved, which we do. Okay, and that then as part of an important part of our board agendas and all the other acute services that we've got. So I think we will build, on what we've had and hopefully time the updates through the board in the same way. We'll always have experts.
We'll be inviting you back. Sam particularly. But for January, are we ready yet for community nursing review? Anything?
I would say probably not, would you? So we've asked for a product by the end of December, from Mel, and we'll be doing the next week, don't we, to get the first draft of that. I think by the time we review it and get it into shape, I think probably January too soon, Chair, if that's okay.
March?
Yeah.
Okay. So passing on in January, could we have sort of just a people on community by design?
Yeah.
You'll get us all ready for 26,
Yeah.
exactly what's going to do. And then have them vote together everything we've heard from Sharon, Sam and Connie around what that primary care connection is and how that's going to feed into community by design that's led by our trustees. Would that be?
Could I just say on that, the national transformation about community by design, at the end of the day, it's got in the diary, so Isabel and the chief medical officer will be leading that, and we've got the dates, and it'll be between Deb and I.
I just very quickly just raise awareness around the building community capacity programme as well that's being driven by Wales Government through social care. And one of the things that we're doing within the RPB is making sure that we are integrating those two programmes because they are fundamentally symbiotic. So we need to make sure that we pay as much attention to that as well.
So we could pay the code on that together, so everyone's being excited on. So, Sharon, Sam, thank you ever much. And as ever, subject matter expertise is very evident and keep on with the really good work that you and your colleagues do. Jobs well done. Thank you. Thank you very much. So we move then on to board 2 and the integrated performance report. And again, without using corners, we're not going to do the introduction from the but we are going to go straight to specific areas. And if the independent members have asked questions on any of the sections, then the relevant executives will answer those first. Otherwise, we will go straight into questions.
The escalation bit we do first, Chair,
Do you want to do the escalation bit?
Yeah, that's
Okay,
probably
let's
easier,
do
but
that
I'll probably
first.
cover off
That first.
the questions that may be going through. I'm just trying to find it. There we are.
Yeah.
Okay, so by way of time, this is relatively straightforward one, Chair, because there's not an awful lot of change with our levels of escalation. Unfortunately, that means we haven't been de-escalated either in some of those areas. It's a little bit disappointing seeing the improvements we have made, but hopefully that will come over the next coming weeks now. So we still remain in level 4 for our maternity and neonates, finance and strategy planning, performance and outcome related to cancer, urgent emergency care and hospital-acquired infections. Level 3, which is enhanced monitoring for plant care and CAMS, and level 2, which is of interest in mental health services. It does say mental health and LD there. It is purely mental health in that one, so we'll correct that one. By way of the updates for board this month, the maternity and neonates update is we still haven't had those escalation criteria confirmed. As I'm aware, I did check to make sure, I know they weren't in this report, whether it's timing, but I don't think they've come through as yet. So the work programme, as is outlined through the perinatal work, is still focusing on what we think we're going to have to achieve in that space. So hopefully we'll have a different update going forward. Mental health, the update for board as we've had was today, so nothing new to add to that space. Bear with me, sorry, Chair, my report is bounced all around the place. I'll do it from my head, I don't need to read that. So planned care, we very little change in the planned care space, so we're still doing very well in the areas that we've been delivering against. We still remain the only health board to be doing so. Pinch points remain the same for us is the diagnostic element and the follow-up waiting list. Diagnostics, the main issue remains endoscopy, but good news, the additional mobile unit has now been commissioned and it went live last week. We did have a little bit of a leaky roof with all of the rain and storm closure, but that's been resolved and that's now up and running, and we remain on track to deliver what we said we would do through that unit. You will see through some of the numbers in the report that the diagnostic weights over 8 weeks have increased. That is purely as a result of the additional work we're doing on the outpatient work through the CAPSEX promise to reduce the waiting list. And obviously, as diagnostics is an 8-week target, they tip into that relatively quickly. We have had assurance that they will fund the additional work required to do that, and we're working through the mechanisms of that with our Welsh Government colleagues at the moment. It is predominantly MRI work that's coming through in that sort of MRI CT work. So at the moment, you'll see those numbers going up. I anticipate they will come down. On the endoscopy element of that, the commitment we gave with the mobile unit was to clear the backlog at the time that we put the business case in. Again, because of the additional outpatient work that's going in, that backlog is growing. We will see if we can do more within that unit itself without incurring additional costs. But if we can't, then again, those additional capacity will come through a funding stream through Welsh Government. So that's really positive in that respect. Urgent and emergency care. I'm just going to look at the appendix on this one because it's a little bit misleading if we looked at the other report on that. So you'll be aware we are doing really well in this space and we continue to do really well. And the change since June is quite staggering in terms of our overall performance. But when we look at how we benchmark ourselves against the escalation criteria, it's that rolling 3 months program. So you'll see there for ambulance handovers over an hour, it says it's increasing and going the wrong way and it's amber. That's because we had our best month 3 months ago. August was our best month ever in that space. And we've increased slightly since August. So it's far better than it was prior to that. But that improvement gets lost by the way this is reported. So I don't like it. And I think we need to find a different way so that we give you that trend line of this is the improvement journey we've been on. And we're still doing really well in that space. We are now focusing on the 45 minute. The escalation criteria remains an hour, but we are looking, as you know, on the 45 minutes. And as Abby said earlier, we are in the green and we're normally third or fourth in the hospital league table on that. Obviously, all of ours come through Morriston. And generally, Cwmtach have done very well. And of course, their hospitals are there or routes with us as well. But really, really positive for us in that space still. I'm hoping that with the improvements we've seen across the whole system, we may get de-escalated from targeted intervention into non-sponsored UVC. But by the book, those measures still remain stubborn if they just keep looking at that 3 month trend. Cancer, on the other hand, the escalation criteria was to achieve 3 months on 3 consecutive months at 60%. We achieved that with the September performance. So September, August, and July, I think it was 61, 61, 60. So by that book, we are assured that the reviews take place now out of tripartite, and that should be a review that happens. So hopefully we'll get de-escalated from targeted intervention into enhanced monitoring. That said, there's still a lot of work to do in the cancer space. You'll see from the appendices and the performance report itself where our pinch points are. They're not changing at the moment, but still urology is our biggest contributor to the number of patients reaching that target, followed by lower GI and skin. They remain the 3 tumour sites that we're going to be working very closely with. So Hannah Parsons is with me now as my Associate Director for Plant Care and Cancer. We'll be working together to get underneath those tumour sites. One of our consultants has taken up the national lead role for urological clinical implementation network as well. So there are drivers to show that we can improve in this space. So that'll be our focus going forward as well. I'll hand over to Richard on the hospital-acquired infections. If that's okay then, Chair.
Thank you very much. Particularly wanted Richard to give us a really good insight into the agenda because it's relevant for our discussion on actions we will be taking subsequently in terms of the management of our resources and the identification of the DCAT board was part of that. So Richard, will you want to set the scene for us, please?
Yeah, thank you very much, Chair. So overall, just in terms of taking that broad look over healthcare and hospital as associated infections in particular. Broadly speaking, the numbers are sort of up and down monthly, but hopping around in the. One that remains a real concern for us though is CWC, which has been stubbornly high. And over the last few weeks and months, we have seen some outbreaks on the wards as well that resulted in us needing to close with capacity, which has clearly been a constraint. There are a number of different things that are happening within service groups to address those, which include things like doubling down on hand hygiene, uniform policy,
We're looking on some of those to change cleaning projects, and there's also an initiative looking at how we might use our domestic staff to clean beds once a patient vacates into the area rather than currently is using nursing staff. So there are lots of initiatives. What's important to note about C. diff, and it's different to the other infections, so staph aureus it's acquired through skin contact, and coli is usually urinary tract or gut. And C. difficile is an organism that's transmitted from the environment, from somebody who's infected. Where spores exist in the environment, they're transferred to another patient. While we can note very positively the impact we've had on the flow issues around the front door, as we've sped up our flow at the front door, consequences of nature has meant that we've had even more patients coming through to our inpatient. As we've ramped up our processes and systems for trying to shorten length of stay and increase flow, we've taken more patients onto our inpatient ward. So our bed occupancy and the total number of patients on our wards is higher than it was before. So while our front door is depressurised and we're rightly bringing people in really quickly, we're at the point of greatest need because they're sick and we don't know what's wrong with them yet. And that to some extent has been at the expense of our inpatient wards, where we're noting that we're over capacity and a greater pressure than before. And actually the slight rise that we've seen in C. difficile is at least partially as a consequence of that. So in terms of actions being taken, I've highlighted some of them. I'm discussing with members of Liz's team about how we might reformat our approach to the HCI group. I think at the minute it's not high enough level. We haven't engaged sufficiently high level with our service group triumvirate in those fora, and we'll be taking through some new actions on that. Right, the key to this part is the role that environment plays is absolutely crucial. Flow, occupancy, and good management of our beds, getting patients out of hospital is just as important.
Judge just realised the missed cams, so I have to do the cams out. The report for board this week just shows September's performance. We have seen the improvement. We were anticipating seeing to 58. Just to give an update, October's was 63, so we're continuing to see that improvement coming through. Obviously, then we're in terms of dementia, finance and planning. Planning, we know, is inextricably linked to having a balanced plan, so that's down to finance, and I'm assuming that we don't need to go into the finance bit here because we picked that up through the finance report. So that's all from me, Chair. Thank you.
So any questions? Oh,
Thank you, Chair. Thank you very much for the report. Just 2 points from me. Wanted to pick up on stroke. I know the date is as of September, so I was just wondering what work we're doing along accessing CT scans within the hour target. And secondly, it was mentioned in there the patient experience about phlebotomy, several complaints about the location of Singleton. Just wanted to pick up a little bit about phlebotomy. I know that there's some issues at the moment, there's some delays, so just wanted to ask what we are doing.
Yeah. So the stroke one, June reminded me in Performance Finance Committee this week, I promised an improvement with October's data, so I keep my fingers crossed when that comes through. We will see that promised improvement, but we are looking at really in depth at stroke. With the CT within an hour for stroke, we need to be mindful that for the patients who come in on the back of an ambulance, we get prior notice of those patients, so they are fast-tracked and the pathway goes direct to the CT scanner. That probably accounts for 50% maximum of the patient presentations. Lots of patients present with stroke with very vague symptoms. Sometimes they come in on the bus, sometimes they've been to Tesco's, and they sit in our waiting room. For those patients, that's where our focus has to be, to identify those symptoms at triage very early and get them through to the scanner in the same way. When we look at the broader number for CTs, so in the weekly data I get coming through, we monitor, because 20 minutes is the new target for CT, which is a challenge, but that's the new SNAP target for CT. We monitor the hour, and then we monitor how long it takes to get to the CT scanner full stop. And most of them are around the 4-hour mark if they're not within the hour. So more work to do with those presentations, but we're focused on that one. Phlebotomy, you're absolutely right. We've had lots of concerns coming through on the delivery of our phlebotomy services at the moment. I think, to be fair to the phlebotomy services, it's been one of those unloved services across our hospitals, and we've moved it, as we've done, particularly the changes in Morriston. Phlebotomy has moved around everywhere. We've been uncertain whether we've got a devolved service down to practice level, down to cluster level on in-hospital model. So we've got a new assistant director in looking at our phlebotomy services at the moment. I've asked him to do a review for me on what provision we've got there out in primary care, because clusters do phlebotomy, but not all. And we're linking in with Sharon on that one. But in the very short term, to make sure we can reduce the waiting times for that, he is pulling resource from a ward level into the phlebotomy services to make sure we can reduce those waits. It will mean increased demand on ward staffing to do the phlebotomies. We'll be reliant on healthcare support workers, obviously now with the new bandage, to pick up some of that work for us as well. So it's not going to be an easy one for us to resolve, and I think we need to look at the options for that. To do anything immediately would need resource, which obviously is a constraint for us. But I think if we review what's out there, what's the feasibility of it, what do we need in primary care, and then how do we develop an out-of-hospital phlebotomy service. The last thing we need is patients coming to hospital to have bloods taken unless they're in hospital for something else. Can't park, it's chronic, and we don't need the footfall. So Richard Price in Morriston Service Group is looking at that, and we'll have a paper on that relatively soon. Yeah, I could say we can have that in January board, yeah, no problem.
Can I just add to that, from a patient experience perspective, we have seen those issues being raised, and it is about the waiting, the way that they're treated, etc., etc. So we're working alongside to look at that patient experience and what can we do now to make it better. So working with those teams who are there now to see how we make it better for our patients.
We do have an electronic booking system for phlebotomy, and I did ask, could we break down into that to say, okay, where's the patient live when they're booking it? What's the GP practice? How long? When did they book it? How long did they wait? Unfortunately, none of that is captured in the electronic booking system. So that would be useful if we could include some more details in that. Then we've got something to work at, so we can see then where our gaps are.
I'll come back in later on that conversation.
So on this one then, we're going to take people will come back in January on well. And I think we need to sort of bring back stroke services into any body of the report, so we not have all the detail in the detail room, I think.
Okay.
Abby and I were just talking about that. It's important that we need to bring it back into the body of
Just on structure, we've just had to choose national stroke standards that we've all got to do a benchmarking exercise against. So we've been to see how we fare in that, and all have both been in a very similar position.
So we will obviously consider that then and taking actions to jump. So that's fine. So does that take us then on to forward to November IPR? Yeah, is that right, man? There's a bit of overlap. Yeah, so yeah, I think we will have to look at trying to streamline this. Absolutely. So, Darren, you start off on this, although we're not going to take introductory 5 minutes or so from each executive.
No, but I think what we reversed over here to my colleagues is that code on the escalation sheet which is HCI. There is a workforce component and a digital component that colleagues obviously comment on as well briefly, and then follow us informative questions. And obviously they'll lead you at the first part of the APR is the population outcome.
So if people can be really brief, because we need to move into areas of questioning and then get to the substantive item around the
18 minutes prepared to do the comment.
Thanks, Dan. I'll be very brief. I guess the key thing to highlight is a challenging quarter ahead for digital implementations, predominantly around the national programs that we're working on, super laboratory system, radiology, maternity. We talked about real already, the mental health solution. So 4 big implementations in quarter 4. We prioritise our resource with digital and across the health board, but challenging but hopefully successful.
Through this of me not to mention quality and safety as well, instead of about waiting to bring this into our roadmap.
Give it a non-verbal one, obviously. Oh, do you want me to go now?
Yeah,
So just again, an interesting time for us to concentrate on sickness absence, which is the key performance issue around workforce. And that we've seen an increase in October to 7.4%, which compares to 7.2% last October. Interestingly, I think the question was raised about seems a high number of unavailable days. When the breakdown of the table you've got in the report, that's a formula that's used by all health boards for consistency. So what you do is basically look at the whole time equivalents you've got, and then times that by the 37.5 hours and take off annual leave and other availability to break it down to available days lost to sickness absence. So actually, in fact, it's 29,732 lost days. That's 7.4%. That's how it works out. Interestingly, the work that we've done on focusing on long-term sickness absence cases, we have seen a decrease in long-term sickness absence by 0.5% since last year. However, we have seen an increase by 0.7% in short-term absence. I thought that might be driven by seasonal flu, etc. It's not. It's all related to mainly to stress, S10, mental health. I think some of it driven by the band 2 to 3 issue in October. So what we're doing is making sure we put some preventative support in place for those members of staff to stop it turning into long-term absence. So we're doing the stress assessment and the signposting. That's the main highlights from the sickness absence.
Thank you. There's two things I wanted to highlight, two quality priorities that we're doing really, really well on, which is falls and pressure ulcers. We've heard about the award that was won for the system-wide falls piece of work, but when we look at the impact that work has had both in hospital and out of hospital, we have had an 8% reduction in overall falls, and falls with harm continues to reduce. The work we're doing with care homes is helping us with RED and NIU admissions, the work that we're doing with WASP. So I just wanted to highlight the good work that's going on there. And also with pressure ulcers, we've had a 50% reduction in serious harm, got good reporting, good response, still lots of work to do, but the quality improvement processes are having an impact across the health board.
And that's the thing, thank you very Jill on the population health aspect. Thank you.
Yeah, thanks very much. So just on some of the indicators for responsibility, healthier and equal lives. The childhood immunisations data that you see is actually due in the table that we do now have the September figures. So for the 4-in-1 preschool booster, we now have 90.9, as opposed to the All Wales average of 89.4. For the HPV, by the age of 15, we're actually leading in Wales now, so we're at 85.8, opposed to 79.4% for Wales average. On the influenza, obviously what you see there is a snapshot which is now being replaced with the new flu season. So we actually are at 60% for the over 65s. That's in line with the Wales average. And then for staph flu, which isn't there, but I think that you would like to know that we're at 39.4%, which is in line with the Wales average as well. But we have really got off to a quick start this season. So we've had immunised in the first 3 weeks, half the amount that we had immunised in the whole season. So a huge thanks actually to all of those involved with policing the state for us to immunise in and encouraging the vaccinated and working with colleagues, Richard and Liz and Chris and so onto the smoking. The smoking annual target 5%, we're at 3.9%. Some of this is to do with the fact that our community services are doing Wales, so we need to work with them to understand how we can do better. The 4-week quits, CO validated, we've actually got quite high 4-week quit rates at 60%, but the
CO validation has fallen to 26%, and that's because so many of the appointments have been chosen by patients as being virtual. They find it very convenient, they don't particularly want face-to-face, and they're not actually presenting where they can have their knowledge of the CO. And so that's something that factor into future indicators. The inpatient smoking cessation obviously is our own duty, very essential for our maternal services and high-risk groups. If someone's smoking was an anti-cancer drug, every cancer patient should have it because it will improve their chances of any of their treatment being effective. And also, obviously, our cardiovascular and our respiratory infections. But our services are fragile, and we are bringing the population health paper on that next time. So screening colonoscopy is 90%. The target nationally is 95%. We're not doing too badly. We're up moving with violence. Our newborn hearing screening is very high, 99.1%. Excellent. And the newborn blood spot is 99.6%. So we're well in excess of the targets for those.
Okay, let's try and pull this together. And Francis, you know what we've done? If we just have the one opposite report on this, on our report, but I am completely confused, I have to say, in terms of where we are. So what we've done then, so we've looked at a government, a Welsh government oversight and escalation tactics. Yeah, and that's really what you've taken us through there as well. And then we've looked at the key performance again, key measures and targets that we have. Okay, so and is everybody content with what we've done through the discussion and what we've heard, or does anyone want to raise any questions? Really quick comment out to make whether we wanted to, I agree with the comment about the paper because a lot of what we've just been talking about is in the reading room, and I think it's helpful to have it one place, and I think they're getting confused by that. But I did wonder whether, Deb, in terms of the urgent emergency care, which came in the escalation, because obviously there's an overlay, whether we want to pick up anything about delayed pathways of care, a bit more explicitly, because Richard, you were certainly going to come back in terms of capacity, whether we do that here or in the finance bits, but it might be, it's a real driver of our performance. Is that right?
Yeah, that's fine. That's fine. There were two additional bits I was going to pick up in the performance report. So delayed pathway care is one, and theatre productivity and efficiency the other. So for me, that's just to update the board. It's a big agenda item for us going forward. So we're taking the paper back to the finance committee in December on it, and we're working really closely with Deloitte this year and going into what next year looks like for us. And we've got a planning meeting next week to start looking at our data infrastructure and how we improve that. So just to give assurance, that is a priority for us. Delayed pathways of care, you can see from the data in the graphs. Whilst they don't seem to be worsening too much, they're certainly not improving by the way we need to. And the number of days is starting to go up as well. So it is a concern for us. We know we can manage the flow in Morriston when we've got the reduced number of clinically optimised patients in, and we've got that flow working through. There's a graph not included in this pack, unfortunately, but if we go into the public accountability meeting, that gives that direct correlation between the escalation levels at Morriston in particular and the whole system and the numbers of patients in the clinically optimised cohort that we're looking at. And you can see our escalation level going up as the COP number goes up as well. So we absolutely need more focus in that space. Again, Deloitte is supporting us very well in that space. To be fair, they've got some really good people helping us. We've got two workshops coming up, one on Monday the 1st, one on Monday the 8th. Multidisciplinary approach with health board, acute colleagues, primary care colleagues, and local authority to make sure we are all cognizant of what they ask of us in all of our different areas and working together on the same script to get these patients moving. We have got a number of extremely complex patients stranded in our beds at the moment. We've got 8 that we know are of no fixed abode, that we cannot move on out of the hospital bed, and as we noted earlier, they're almost resident now in a hospital bed. It's not good for them, it's certainly not good for us. So we have to work differently in the local authority space to make sure we can move these patients on as well. There's work for us to do in the reset week will be for execs to observe the work that we've got to do on the boardroom space to make sure we are being proactive and managing in the best way. For that, lack of reduction in that space has now started to run going ahead of it.
And that is going to come up certainly in the public accountability meeting. We, I was just going to say, we discussed this with the on Tuesday, and in particular, obviously, it impacts on our finances. And while we've got so many COPs in our beds, we're unable to reduce our surgery beds, and that is one of the areas that we could get some savings if we could reduce. And it does seem to me that we are really going to have to get more consultative with colleagues in local authority settings, given the extra money that we give them. We have that discussion, didn't we? Good.
Okay, so please,
I covered that, I think. You know, I have lost this on this. This particular item, honestly. Thank you. So, yeah, Ms. George. Right, so we have then done as much as we need to do then.
We have, thank you.
We have. Right. Can we move on then to finance?
Thank you, Jen. If I can make this as clear and straightforward as possible, given the range of things we have to do to try to resolve the financial challenges we find ourselves in the report. So the report before you today is the 97th financial report. It's the end of October edition. Our report contains two elements. It obviously goes to the 97th position in some detail. It also goes to the action that takes place over the course of this week, through yesterday evening to our next board. But because it's this time of year as well, I just want to draw the board's attention to the strategic aspect of the report as well. That's an actual sign up several times. The report in section 3 on page 4 reminds us of our standard deficit forecast for this year, 8.7, and the need to save 55.4 million. As I've mentioned, this position, which I will take the time to go through here today, has already been reported to independent members. So briefing processes in two sessions, a detailed way in private and also a very thorough way in open session as well. So in terms of the overall revenue position for month 7 and section 4 of the report, page 5 sets that out for us. And once we reported a 4.13 million deficit in month 7, which is our best position to date. It's not where we need to be, and we need to improve further. It takes the cumulative deficit of the health board of 7 months, 47.16 million, and that is 12.9 million above the straight line plan we had at the start of the year, effectively 7 times. And in order to achieve the forecast we forward ourselves to 8.7, we now only have 11.5 million maximum headroom in the next 5 months to achieve that, which equates to an average of 2.3 million months. Our best month being 4.1 in the scale of movement when we come to month 7 where we need to be. The two key elements of under delivery within the plan, the first being 6.8 million of schemes we developed with our financial partner. We own those schemes, they're not their schemes for us. We're with them to do that. And at the time we were putting this report together, and the discussion we had on Tuesday about the report tonight, there was none of those schemes that moved from red category to green. Secondly, there's a 9 million contribution to the overall plan, which relates to 6.2 million of pay control, about 800,000 pounds of planned care, benefits realisation, and 2 million pounds of non-pay control. And that 9 million, with 6.8 million, is creating driving the gap towards the end of that. In terms of labouring the point of the board, those are the things that we must deliver to achieve the state debts. We'll go risk mitigation in a moment, and we are in critical juncture in terms of doing that. And I know the colleagues who any conversations after the conversation are fully aware of that, fully aware of the collective role address it. Equal importance is the 6.8 million pounds of schemes that we have with our partner, drive 30 million current aspects next year. At the moment, the current translation of this year's savings, and we've got 40 million pounds of savings on the books, only 20 of that 35 million gap in next year's savings plan. Doing the 6.8 this year will give us a significant closure on that 35 million gap by 30 million next year. It's fundamentally important as we think about next year and the settlement that we expect from us government. We need to start next year where we ended this year and not have the potential and leg ups emerge in a different wait because we have to address it. 6.8 is 30 recurrent, and we've got to address the next. On page 6 of the report, you'll see a new table which I've brought, which is called one-off medications. There are a number of confirmed lines on that. That is just the output of some of the work we've been doing at this time when we started looking at the where we can change perhaps visual assumptions, etc. That work nearing completion, I'll be able to bring in December. Realistically, the scale of that will not override the need to do the two things I just said. We must do delivering this was fundamentally key. We must deliver the 6.8, we must deliver the 9. Anything else I can bring. But it probably led a particular message here rather than the bottom. We shouldn't rely on that. There's just hopefully good. In terms of the composition of the plan in the detail, pages 7, 8, and 9 reports do that across the tables. The conversation they talked about variable pay, the mental health placements, the delivery of activity, the must meet the targets, they all factor through the financial position. Fundamentally, the savings gap becoming to do our driving the risk calculation where we are. Pages 10 and 11 I've just set out the capital position that gets more certain and reviewing underlying central balance CRL. Pleased to report that this week we accepted the 1.6 million of discretionary capital, we bid for the year end do the 3.3 million pounds for estates and medical and use that up against the risk stratification to good work. And in the next day or so, I'll be asking for some urgent action on that set equipment, pharmacy robots, fluoroscopy equipment to consume that and extend it well before the event. It's a really strong good news. For next month, I will be able to reduce the risk of CRL. At this stage, I cannot reduce the risk of balance sheet details, as I said, in section 5.3, and there's a bit more substance in the cash section of 5.4, just picking up the need for the right for strategic cash to manage cash at the year end, to pay bills on payroll. That letter, in all the machinery of that, suggests we'll need £5 million cash injection, strategic cash at the year end, which is broadly in line with the forecast deficit position. There are bits and pieces that will allow us to make cash flows. The payment regimes on page 13, which we're achieving, and I've touched on this. In the closed session of the board, pleased to report that the majority of the risks on the table you see here will be built into the assumptions and forecasts. So the gap of 50 remains that gap. Be very clear with board though at this stage the solution to Welsh School not in our forecast. Anything outside of that is a risk. The majority of the Welsh Health Councils are doing the same, and that's been very transparently related at a number of different levels across Wales, specifically when we're going to change that as well. There is no resolution for that at this stage, but we're hoping that assumption may well be the last stage. So that's where we are. Really helpful scrutiny challenge this week. Know where the challenges are, touched on them, not just team of discussion. Clearly the optimized patients are clerically impediments to some of the digital care solutions that we have. We are reviewing the investment decision. Team has teamed out the challenges around availability of staff, presentation of assumptions, how those are playing through into the variable pay bills. The variable pay bill remains unchanged. 4.7 million. That is one of the key areas that we can influence. And as an executive team, and we will do this further, we've started to discuss our risk tolerance and variable decisions. We will do that in a balance of quality, safety, and workforce responsibility. They will be. In terms of rhythm of work, as a result of where we find ourselves, we will be having weekly workforce metrics. Our finance partner will act as a critical friend in that test us on that. We'll be able to see by individual approval what's being granted across all staff groups. That's how we that as well, which is a step change. I won't comment more on the detail of RNS, but we went through every individual line of the 6.8 million RNS last night. So using a lot of somebody to account with service groups. We believe we made a step forward into that. We will know that it went because I don't want to give an estimate today to go from some validated later on, but we have moved through that. And without certainly giving compliments on the 6.8, I think on the 9 million, we've got to see the dial to on the opening assumption. And that's where we are as the nature of find ourselves in those things that we didn't answer in the last week or two.
So, Rina, I'm going to ask you to come in please. We report on advice from PSC for rules.
Okay, well, we had very detailed Darren referred to the discussion the next 4 months. But in summary, the committee were not very confident in terms of their level of assurance in terms of reaching our deficit target of 58.7. And that was primarily because the run rate is not coming down fast. And the savings in relation to the executive led fees and enhanced controls have not come through on the savings tracker ledger. Although obviously that may change following the meeting yesterday, which took place. In terms of immediate actions, there were a series of actions that we noted, so I'll just quickly go through them. The need to convert the red savings to amber and green, which I said referred to yesterday, the flower. An agreement on the reduction of the bed base, which we feel will be challenging given the winter pressure, the increasing demand on the team and the relatively static COP numbers which is to that. However, there is a move to open a step-down ward in Singleton with 50 beds to provide non-medical care to such patients at a lower cost, which may improve flow and allow the closure of some of the surge beds in Oxford. There needs to be a change to the risk appetite in relation to variable pay to enable the review and rejection of variable pay requests, and this change must enable the executives to say no to some of the variable pay requests in the short term to enable the savings to come through in the last 4 months of the year. Deloitte is putting in place a weekly meeting with the executives to review and challenge variable pay requests, and the committee will receive updates from these meetings. There needs to be enhanced delivery capacity, including addressing the program management side of leadership, and especially in relation to nursing, where we noted from Deloitte they were concerned about the capacity in that area, and that's no criticism of this. Capacity. There's a need to enact and embed the performance management framework, and to make sure that it's fully embedded in starting Q1 of 26-27. And we need to be thinking in terms of planning for rebasing budget for 26-27. The view was that we need to see that it enhanced savings coming through, particularly in terms of traction on the trackers, by the next meeting in December. And we felt it would be helpful for the members of the board to meet with service group led leaders and the executive directors of the key areas to discuss how they are delivering. This was felt to be vital to allow the independent members to interrogate financial delivery at the branch level. The last thing was that the members of the committee also wanted to have visibility of the outputs from the Deloitte's work, which my understanding is now coming through to the executive before the issue at the moment. But obviously we'd like that to come through to the committee next time. I would like to open it up to Steve, Jean and Louise, because obviously there was quite a long discussion on it.
So Steve, do you want to have a look there? And I'll come to Jean and Louise.
Yeah, I mean, as you know, I wasn't at the meeting on Tuesday, but I viewed the recording at 37,000 feet over the Indian Ocean. And two key things I noted. The financial advisors at Deloitte, they were clear that they thought there was a route, they call it a route to cash, didn't they? They thought that they had found us a way where we could get to the objective. But we had to do something. We had to grasp the opportunity. It was mainly about variable pay, and I got the impression from those guys that they don't think we have yet grasped that opportunity to reduce that. And we asked Darren's number 2 whether she thought that, sorry, I wasn't there. They asked Darren's number 2 whether they thought that the November numbers would be getting better. And she said there was no evidence that that would be the case. So we're at the 27th of November, month 8, and not much hope in Darren's team that that number is going to be effectively coming down. That was my the main takeaway from that viewing that meeting.
We did have a very in-depth meeting, and it was challenging on both sides, I have to say. To me, one of the overriding messages, notwithstanding, we gave a couple of opportunity areas to look at, such as understanding with more granularity exactly where we're at. The 6.4 million in Morriston, that needs to be delivered at pace. We talked about losses and that debt provision, the TABI activity, how many patients does that relate to and what are the costs? So we did go into granularity under the overriding statements. For most of us, I think, at that meeting, the frustration was it feels a little bit like another talking shop. We've talked about performance and management, and we know everyone's working really, really hard. We know the staff are feeling it, and we appreciate that Darren and his team have worked hard, but there just seems to be no accountability and responsibility for delivering what we've asked for at pace. So we find ourselves in a position, I think, well, I don't think, we find ourselves in the position where we are where we said we would be. And as a performance and finance committee, despite all of the information, and I use the 6.8 million and 9 million you talked about, which you've discussed since the performance and finance committee down. That we were told by Deloitte we have to have a forensic approach to cash management. There is no point in using twee words that are not underpinned by action. So we just cannot understand why the performance management keeps coming up time and time again. And you just mentioned at your recent meetings, you've looked at clinically optimized investment, availability, variable pay. These have all been on that agenda since the start of the year. So we were quite disappointed, I guess, and we were hoping that more would have come out of your meetings with Deloitte, etc., yesterday and the day before. So at that meeting, I think we were clear, Darren, weren't we, that we were somewhat disappointed to keep revisiting the same criteria over and over again with no real impetus in delivery.
Anne-Louise, I'll turn to you.
Thanks. I think it's mostly been said. I think my takeaway was that Deloitte's assignment in particular emphasised that he had turned around 20 plus organisations, and the message was, therefore, I can do this. But there was no granularity on it. We haven't seen what he's actually doing. I did sense significant frustration because he obviously had been successful elsewhere. But I didn't really get an impression of why we're not being successful if he's done it before. Is he doing the same thing? Is it familiarity? I don't know. But it was, as Jean said, just disappointing that we haven't made the headway that we should have done by now.
Just ask if any other independent members want to come in before I turn to.
Jan, before I forget, if I may, one of the things that I mentioned, which you passing evidence of apparently because you were at the same awards presentation as I was. The work that's been done in the cardiology unit with having a pharmacist on site in that pharmacy initiative. One line, one product, they made a saving of 85,000. So what are we doing about looking at the good practice that is across the piece, but we're not implementing it to get those kind of savings?
That's a very helpful example there. So Nura, do you want to come now?
I think it's disappointing. I think we've been here before, and I think I can sense the frustration on both fronts. I think that there are elements that in the audit committee we've welcomed. So the Recovery and Sustainability Board we've welcomed, and there are clear signs of accountability now that we haven't had before. So I think that there is progress, but we're not seeing that into material. I think that's where frustration is coming. I think there is going to be a new delivery unit, I understand, from some of the discussions that we had in the audit committee. And I think for me, there is a bit about tightening our controls, which I acknowledge is somewhere we need to be. And there is a bit about the long-term vision of where we're aiming at. And that savings, benefit realisation, and productivity gains looked alongside our bigger transformational piece. There's a lot that we're doing that is going to get us to where we need to be, but the pace is not where we want it to be. And I think it's just acknowledgement of that. I think for me, I have to ask this, Darren, in relation to audit, which is, are there any risks associated with the 1.2 million from the balance and adjustments? Is there anything we need to be aware of at this stage? And then we've said this before, which is, we need clarity. The paper says that this savings limit of 4.69 million against the target of 4.62 million. But this is always one of the problems, is that, we need to come up with the targets, the monthly targets set at the beginning of the year for the average amount of savings that need to be delivered, or is this the target for the amount that we now need to save in order to get to the trajectory to deliver our intended deficit? And this was one of the conversations that we had at the very beginning of our journey. So I think it's that clarity, that granularity actually would give us some comfort, but we don't have that at this stage. It goes back to some of the comments we made in things like that. That's my personal view.
Andrew, do you want to add anything before I hand over time?
Well, just again, I would reiterate the comments made, but I think for me it's the variable pay thing that's hard to fully understand, in that the figures haven't changed, and yet the sense I get from the organisation and even around the board is that there is a downward pressure on that, and I can't quite understand, is it because variable pay requests have increased so much, we are having a downward effect, but not enough, you know what I mean? Or whether just there's a cultural feeling that is going, there's pressure on it, but the actual result is the same. And clearly stating the obvious, it's feeling very much like the variable pay bill won't be big enough to push down to get to the savings we need. And that's the hard thing.
Should I turn to you?
Yeah, thank you. I will try to walk our way through this and cover all the issues and down and other execs I'm sure will want to chip in. So if I use the framing that you've given us and Rena as the way that we walk through it, because I think it will pick up the other issues. So in terms of the red to green on the exec sponsored portfolios, what we can say is that yesterday's sustainability was a really constructive meeting. It was probably our best meeting in terms of everybody being on board with the things that we have to do. There are some very clear greens that are now on there and good numbers against them. It doesn't completely close the gap, but it's getting us. I was trying to tot it up, Darren. It was a good move forward in terms of where we need to be. The areas that that we have got to go further on, as you say, is the variable pay. We will bring in your point about the granularity. We've now agreed that we're dedicating the first hour, 3/4 of an hour to our monthly informal meeting, just as we run through all of the metrics on operations. We'll be running through all the metrics about what requests came through, what was approved, both in terms of the vacancies and in terms of approvals. we have, except as execs, we are going to have to hold our nerve on the impact of saying no. So some are now coming to me, and I will tell you that I said no to all of them. And I then had a message which is, do you understand the implications of this one, and this one? And I did move on those. So some, and we need to change this, some are directly related to the weekend activity we are doing, which is paid for by Plan Care. Now that's expensive because it's being paid through on a very generous overtime rate. And we need to make absolutely sure that there isn't a skewing towards staff wanting to do that, because it's generous hourly pay for that, because we're doing weekend pay. So our scrutiny about making sure that it's not last minute, that we've got to do it over the weekend because we didn't do enough in the week. So our performance management of that is really, really important. And some of it we may need to. Some of it is that we're going to have to hold the nerve and there'll be a service impact. So one was phoned in sick on radiology in Port Talbot. So we would have had no receptionist on in the minor injury unit. I'm sure they would have found a workaround, and the issue is we just need to hold our nerve and that, and so no, you're going to have to find a workaround. But that is going to cause, there will be noise in the system with some of those things, and we're just going to have to accept that there's going to be noise. I think this is a point that was made when we discussed in the exec team, most of our exec team meeting on Monday to talk through this too, is we do have to make sure that the safety, that our kind of impact assessment is understood. You can't do an impact assessment on every single post that comes through, because they're already, the process we've got is already very intensive, and as Deloitte have already explained, it's a really tight process. It's about holding on nerve on the final decisions that are being made. And what the clinical, the service boards or the groups will tell you is that what we don't see is the ones they've already rejected. So we've accepted as an exec, we need to hold our nerve on those. And we will bring them in every Monday to see what's been the impact of last week's. Same on the medical agency, so Richard's working through. If we have got a hard to fill consultant post, for example, that we're filling through local, we are working very hard to work those through. But for example, things like radiology, we don't have enough in our current workforce to deliver the demand, and we have an outsourcing arrangement or a different way of paying for that comes through the variable pay route. We are forensically going through those on saying what could we stop, and also tracking what's coming through from an operational point of view around we didn't have enough ED and docs on over the weekend, or we're not going to have, so how do we enable that? But making sure that in the weekly monitoring we're really gripping down on that. In terms of the performance framework, completely agree with you. We agreed that last summer, and I think we have to be open with ourselves that as an executive we haven't really bitten with that and used that as a framework that brings together our service group reviews on quality, performance, and finance and workforce. And whereas they spent a lot of time generating a very detailed information pack, we've agreed that we'll provide that centrally, but it's too light now. And we need to bring all of those things together. And we've got an escalation for service groups, but at the minute they will be in high levels of escalation because we're not delivering. So tightening up on that performance, and we've agreed that from January we'll have those in place. And you recommended that's embedded. Needs a little bit of tweaking. We talked about assurance, and we've talked about the accountability word being really explicit in that. We will do a session with IMs in terms of walking you through what we do in recovery and sustainable, so you can see the level of detail, you can see the challenge and conversation, and we can bring leads and service groups and the key leads and the service group together. And then the final bit that hasn't really been reflected in the discussion is around some of the reason that we are here is because of the investments that have been made. So there is an agreement to go through line by line. Well, we are doing the work, and Deloitte have done the work. Some of those work relate to emergency and urgent care. So Deb is going to use the Six Goals board to go through those, and some of them are where we've actually just got service baked in, and we need to agree that that's not where we're going to be able to disinvent in 1 year, in this year. We might want to remodel that service and do something different. And then, Jean, your point about things like pharmacy, we have asked to push harder on pharmacy because it is an opportunity both in terms of what's prescribed, but also in terms of how we use our pharmacists to do what you said. If they're sitting in the MDT alongside, then make an impact immediately rather than having to correct things that come out when the MDTs happen without them. And I know that's a model that they want to roll out into other places because I think it is a really good model. Two final points, we've already talked about the move to Singleton with the ward. We will have the granular detail on what that will mean on the bed model and the savings that we draw out. But if you look in the reading room and the performance report, it just shows, alongside that, we'll be taking out the surge beds we've got in AMU and on the ward. That is our plan. But if you just look in the report in the detail, it gives you an example of what it's costing to run those surge beds in pay. And again, we have made such progress on unscheduled care. We've made such progress on emergency urgent care. We're just trying to find the right balance, but we know that we're going to have to push harder. And some of the things that we will need to press the button on, we will need to bring back, and I think you will need to have full understanding of potential implications. So we've talked about things like how we're running the minor injury unit in Newport Talbot, because clearly that's one of the areas where a big investment went in. It was intended to extend the opening hours, but what it did was short up the staff because we've seen a big increase in the volume of activity. We need to again look really closely at when we deliver that service, when we get best value for the investment in it, with a view that we need to take at least some of that out. And similarly, there'll be the as we said, the surge that we've got open, we will need to bring that out. It is a difficult time to be doing that going into the winter, and we need to be bringing, as we're currently doing regularly through the processes we've got, updates and any risk associated with that. So in terms of the red to green, we've already got an update. Darren, we gave close of play Wednesday with some of the further pieces of work that we've got the activity, but we haven't got the number on it. And of course, the criteria for something going green is very, very specific. Needs to be transacted onto the expenditure on the ledger, and as you were saying, Jean, the cash that hasn't come out, so that we have got a number of things where we're really confident they'll deliver, but it's about being absolutely specific on what the cash out. And on the beds and the move to the Singleton ward, we've got to get that right in terms of the staffing model. So Deb's team and Liz's team are working really hard on that. So it's non-doctored model. It will be looking at 2 healthcare support workers, because actually we should be providing the clinical care. Personal care is more the area. Of course, it will need to have nursing oversight. But we want to put a range in, because we may not be able to nail that down by next Wednesday, but we put a range in that. So you will get an update. And we can do that at the back end of next week, Darren, can't we? When we get the quarter next monitoring reporting time frame of how much we've shifted around that. I think that's picked up most of the comments from Rena and other colleagues who contributed.
Do you want to come back in?
I do, because there's a lot in that, and there's a lot to welcome in that. We still need to see those cash that you was referenced to, but I think that for me, there is a huge culture piece in this organisation that we need to talk about parallel to where we are with the finances, and that needs to also be prioritised. And once we have these governance systems that we're putting in place, this needs to be owned by everybody in this organisation. And I think that's something that I would like to hear more about, Abby, in terms of what we're doing there.
Yeah. So 3 comments to make on that. Completely agree. Because of course we've got to get the variable pay down. We've actually got to get the pay down, and we need. Tina's done a huge amount of work on what's been our journey in terms of workforce. We know all of the detail of what's grown. Nursing has been the biggest growth. So one of the things that Deloitte recognised, and again I think it was previously talked about, we need to make sure that Liz's team have got the resource they need to drive the reshaping, because that's ward by ward, community team by community team, reducing the layers. So all of the things we've described in organised for success is absolutely there. We've got a de-layer, we've got too many layers of hierarchy, and we want a much flatter and less hierarchical structure. You're absolutely right about the culture. We have a culture which is too tolerant of failure to attend for work, whether that's sickness absence or whether that's other reasons. So we're tightening down on training. Mandatory training is where we need to focus our attention, but we have a culture around sickness absence. I talk about it in every Ask Gabby every month team brief, which is a cascade system which has about 150 people on it. We had that, was it Wednesday?
That's
Very
on
long time ago.
Wednesday.
It was only yesterday.
Yeah.
In terms of cascading it, you'll see that the weekly and midweek message that goes out to everybody, it pretty much always has a discussion about the money. Richard's team are doing some really nice infographics about this is everybody's job. But you're right, that's why it's getting harder to turn the dial on it. I think team has previously talked about using the absence policy to best effect. It is there, the policy is there. What we do know in certain pockets is the staff are not using it to manage sickness absence. We have the highest sickness absence of any of the health boards. I don't believe we've got sicker workforce. So we've got to make sure that we're using our policy and appropriately supporting staff, because we do have a really extensive occupational health service as well. So making sure we're targeting that to the places we need when staff are genuinely off. My understanding, because I asked the question explicitly in the room with Liz and Tina, about are we flexible enough for things like phased return, supporting people to come back, and the feedback I've given is that we are pretty flexible in terms of enabling people to come back. Perhaps too flexible in some instances was the feedback I had. We need to make sure that there isn't variability in that if we're consistently applying the good practice around that. So I completely agree with you. The other thing that an email is going out today is around top 100 leaders, so including clinical leaders, because that's actually where we commit a lot of the resource. It's not service managers, actually, it's clinicians committing tests and admitting patients and filling our outpatient clinics to maximum or not. So there's a lot of work that aligns with the productivity and efficiency agenda that we are pushing hard on. So we're forming a top 100 leaders forum. We'll need to get that right, might need to tweak for different audiences. And that will be where we bring everyone together to say we need you to lead out in your service groups. And it also plays into the fact, which I did miss, the point you made around planning for next year, because when we come to the board development session in December, which I think is the 17th, I think we're going to switch we might have to just change the timing of it, I think. But we'll walk you through the analysis from Deloitte, the underlying deficit work, how we're approaching the planning, because we're taking a different approach. It's not kind of bottom up at what we need to do. It's this is the resource. What can we do when we're aiming for upper quartile performance? You can't switch that on overnight, and some of it's the infrastructure we've got in place. Some is the fact we've got some surgeons are operating on 3 different sites. That can't be an efficient way in which we use their time. We know that some of our start times, finish times, we haven't got a dedicated 23-hour, 59 minutes day case unit. So there are some issues about how we capture and record some of our day case activity, which doesn't look as good as it probably is, actually, because of the way it's coded, in terms of if you come in as a day case and then stayed over. So we've got lots of things to go at, but this is a very long way of saying, Jan, completely agree with you. We've got a lot to push at, but it means that we've got opportunity as well, because if we didn't have opportunity, we would be feeling in a much more difficult position. And collectively, we've got to ensure we take our staff with us on that journey.
Jean, then Tina, then Dana. Jean. I think one of the things that we have to reiterate is that we have said from day one that we're on a 3-year trajectory. So we cannot lose that 3-year focus, whatever we do. But moving into that 3-year focus, I think it's really incumbent on us to understand to the penny what underlying deficit is made up of. Because unless we understand that, we can't manage it going forward. Alongside that, based budgeting is absolutely vital. Because I think I read somewhere, Darren, you probably will know straight away, that we are 55 million short in terms of what we should have to run and what we do have to run. Do you remember that in some statement in one report I read? Well, if that's the case, we have to make absolutely sure that we know what it costs us to run every single service that we do. The other thing is driving out malpractices of keeping stock rooms full to the gunnels to make sure that we're not holding cash in places that it shouldn't be. And picking up on culture, this is an opportunity for us all to be seen as the leaders of the organisation. And I know you guys are out there all the time, but it is a time when we communicate like we've never communicated before. Make sure we keep asking, where's cost that we haven't picked up? Because they will have the answers. Those at the front line and those who are delivering will have the answers for us. And the last thing I would say is that unless we've got the opportunity as members of the board as well to demonstrate we're all in this together, we've got ourselves into it, we've got to get ourselves out of it. Remind us of the 3-year journey and remind us that we're not going to give up on this, we are going to get there.
Yeah, I was going to pick up about the culture in the Organised for Success paper later, or I can just touch on it now if you want me to, that'd be helpful to know. So, fully agree. So, when you look at the hard and soft metrics around the workforce, and the workforce is the most expensive resource that we've got in the organisation, there's lots to do in both the culture and management of our workforce and making sure it's cost effective. It's a decision that we need to make as a board because we can't do everything at once. There's lots to do, so it's what do we need to do first, in what order to make sure we get the biggest benefit from that. And so the proposal around the Organised for Success is that we need to make sure we've got the right operational structure, but also the right leaders to lead us through the next part of our journey with the right skills and competences to be able to do that, supported by the single improvement methodology and a reduced number of priorities. So it's a massive piece of work to do, but and the Organised for Success is the first, what we're recommending as the first phase of that. And I'll go into a bit more detail into that agenda item if I can, to bring that bit to life a bit. We're going to juxtapose the agenda again when we get through this, and we are definitely, we've got to take capital estates and organising that. So we'll come back on that.
Darren, you wanted to come in?
I did this to some extent. Jean said that we were going to try to tie together the opportunity around the underlying deficit and understanding the set like budgets. Could you put the each item on that tries to give them accountability and help to just the culture. So in December at some point we're going to bring some proposals around the budgetary framework through in principle to look at to see how we use the budgetary framework next year as part of the 3-year journey, armed with this new information to say this is how we're going to hold people to account through a reasonable allocation and then give you the escalation to recovery. So very much sure and Eugene will see some of that through the next month. So got more tools to be able to do that. I'm also mindful of them. I'll be having that conversation with government of those scrutinies as well, because that's part of the challenge they get outside the organisation, both of which are appropriate. We need to be in the full position here.
And then I'm going to ask Richard to talk us through the implications of the move to Singleton, taking down the search beds. What exactly that means, but that's one of the most radical things you said we're going to do, and that we've got on the table. So we just need to understand exactly what we are doing. But Steve, can you come in first?
Yeah, and then to Jean's point about this being a 3-year plan, from what I've heard and read, the plans that Tina and Liz and others have got in place puts us in good stead for next year and the year after. But in the current year, we're kind of running out of road a bit. And if we need to find 15 million sometime, an emergency 15 million, it sounds a lot, but it's a relatively small proportion of what we spend. It's less than 1%, 0.8%. Should be a way of finding it. So the plan C, that would be, I think we need to get some sight of, before the end of this calendar year.
And that's a conversation we had yesterday, Steve. And we will bring before the end of December. So John, we need to think about how we do that. I think we can do it relatively soon. Some of those options and choices. They won't be easy ones for the board to take, but they might be slowing down certain activity and looking at what we prioritise in the plan care space, in our core capacity, what could we do differently, where it's high cost activity. The one thing we didn't mention in and you'll see it when the underlying deficit report comes through. And Jean plays into your point about our cost versus the service we're delivering, is around our services that we provide for other health boards and other commissioners. So there is definitely something that Deloitte has picked up in relation to that, and that we are working that through in terms of how we have those conversations and how we do that. It's not about externalising our problem at all. It's about making sure that we have those proper commissioning conversations about what we do and don't do as an organisation. And we've touched upon it in some of the other conversations today about services that are actually not very sustainable. So we talked about services where we have to shore them up with a locum that we can't fill. That's not a great model. We don't want long-term locums. My view is that you're prepared to do a long-term locum, come and work for us and be part of our team. But actually some of them are really, really difficult. So hematology, we talked about the women's the Fertility Institute being one where it's really difficult to recruit to. That's a piece of work around how do we make sure we go through around service sustainability. It does play into the clinical services plan because increasingly needing to support and work with Handlar both ways in terms of those services need to be part of that solution. We have talked about radical nature, haven't we? And if you recall, I remember it was the last board meeting or the board meeting before when the Auditor General's statements came out about much more radical transformation. And we need to find a way of taking our communities, our staff, and the politicians who will arrive with us, whether they may be in whatever colours in May. We're going to have a really key way of having those conversations because we can't continue to deliver in the way that we currently deliver, and that needs a much more radical approach. But in terms of confidence, I am more confident that we have made a significant shift in terms of the close. Alex from Deloitte was doing. We literally were updating the table as we went through. If we can, at the end of this week, give a short update from yesterday, as well as next week, to give you greater clarity. Because I agree with you, Steve. It feels like it should be completely within our gift. I also think in the briefing next week we ought to talk through in a bit more detail the sorts of areas that we are scoping in terms of what else we were doing, particularly in our last couple of months, about what we would do to hold expenditure. There are also some other things that we are pushing much further. So we've talked about the value and sustainability board at a national level. Some of it pushing hard on the Just Do It's, but also pushing hard on procurement opportunity. There's more in there than we have planned for at the moment, but again, pushing really hard on those things and actually getting our procurement partner and actually perhaps the senior director into some of our conversations as well to make sure we're driving that at a local level. And again, we might get some noise around that from some of our commissions if we're switching things in and out to get better value or stopping things. Because the other thing we talked about is we will just turn off some things on the catalogue that you can order that you won't be able to order anymore. And we've upped the threshold at which you can authorise approvals on Oracle. So there's a higher level of escalation in relation to that. But there'll be some things we just turn off that you simply can't order.
Thank you. So when we come to the end of this, I'm going to suggest we do a wrap up with you talk through the CMT. Two questions I'm going to ask the board. We have signed up to 55.4 million savings, and we have signed up to 58.7 million for the year. So we need to agree, Heather said we are all in this together, and we need to agree if we still sign up to those, and if necessary, we will need to vote. Because I will need to assure Cabinet Secretary that this board owns this agenda, that we understand how we got here, and that we accept our responsibility to get ourselves out to them. Okay? So, Richard, over to you.
Thank you very much. I've just got a double up with that. So as we highlighted earlier, what is in the plan about the potential to open a water systems for less acute patients and to take down more expensive capacity costs. It's one of those areas you might consider as a difficult choice to make in the context of where we are and where we need to be. So just to talk that through from a clinical professional point of view, just to make sure we're talking the same language, so a patient who is clinically optimised is any patient who no longer requires care in an acute hospital. Now that might be someone as straightforward as waiting to go home, and it's stuck for some reason, waiting for members of the house. Might be somebody with very complex care. But what is common to all groups of patients who are clinically optimised is they certainly don't need to be in an acute hospital bed, a site that's near an intensive care unit, which is what we've currently got at Morriston. And at any one time, a lot of our clinically optimised patients are on the Morriston site, which is clearly where our most acute wards are, where our most unwell patients go. And it's our most expensive estate in the sense of both from a resource point of view, those are our most specialised and highly qualified staff on those sites. And what we do know is that those patients certainly don't need to be under a highly specialised nursing or medical team. They need care, they need physical care rather than necessarily having medical. And those clinically optimised patients will be in a number of different wards, maybe up to a third or a half of some of our acute wards will be occupied by patients who are clinically optimised. So for the clinically optimised patients themselves, they don't need that level of care. They provide the level of care that they require, safe, effective, physical care while they're with us in an alternative location. If you flip that around and consider from the other point of view, that's the patient more acutely unwell, they do need to be on the Morriston site, in one of those beds, under the care of one of our specialists. And our specialists are geared up and are most skilled at managing those really sick patients. And when we've got ward environments that are up to a third or a half full of patients who don't need their input, it becomes a really inefficient place. So we will currently have patients in the wrong place, because we can't put them in the right place, and the wrong specialist team, because we can't accommodate them in the right specialist team. So although it is a difficult choice to make in terms of it will mean us needing to close capacity, the flip side of this is that not only will we be providing the right level of care, those clinically optimised patients who don't need in particular, it will also mean we're more efficient and more effective at dealing with patients when they most need us, and most need the skills of our highly professional and most highly qualified staff. So it is an appropriate thing to do on both of those counts for both of those groups.
I'm going to pull this item to close now because we've obviously acknowledged where we are. We have an approved plan and we haven't reached this one. We've looked at where we are in point 7 and as Sabrina has said, the run rate's not coming down quick enough, the savings aren't going up quick enough. So we've looked at across the board at what we've done today. We've listened to what the executive has talked to us about in terms of what was clearly a very challenging RNS board yesterday. We've heard from PFC and all the things the independent members are looking for in terms of increasing their confidence. But as a board, we are collectively responsible. And we have signed up to 55.4 million savings. So can I ask the board members, please, the members of the board, are you still committed to 55.4 million? Is there anyone who is not so committed? Then we have also signed up to achieving the 58.7 million deficit target at the end of March. And we've heard today we're going to have to take some hard decisions and take some hard action. And we're going to have to hold our nerve. But this is what we're appointed to do. We are the stewards of the £1.8 billion of public money. So I'm going to ask the members of the board, are you still signed up to delivery on the 58.7 million deficit of the year? Is there anyone who doesn't sign up to that? Members of the board. Okay. So we are committed. We have made that decision. We have reiterated those two commitments we've made. And as Abby said, we can now expect next week, Abby, a schedule of further actions we have to take because as Steve said, we have nearly £1.8 billion in play and we are looking for 15 million. So this must not be the right. There's enough collective intelligence and intellectual power in this room to get us to this point. Okay? Thank you. I know it's hard, but you know, this is why we're here. It
is actually what is required. Okay? And if we need to have a special board meeting before the 18th of December for public accountability, then we'll do that and get those extra points through. Is that okay?
Just make a comment, a personal comment, that I accept the responsibility that we have signed up to. It feels very difficult for me as an IM to influence the accountability and responsibility that has to be enacted to deliver. And for me, that is where my discomfort lies, because we all talk, and I know what it must feel like to be out there trying to deliver these messages. But I do know that if we are to accept accountability and responsibility, when executives are up against it, for want of a better phrase, then as IMs, we're here for someone to come and say, this is what the situation is. Do you have any insight, or is there anything? That's the disconnect I feel, because I'm here, and yes, I'm long in the tooth, but there might be something I've done somewhere that can help all of you guys at the front end, because we've all been in those roles. It's not easy, and primary to what we're doing is the safety of our patients, dealing with what they need, making sure that we send them back to whatever role they came for. But I just feel, for me, that disconnect is there. No one comes to me to say, Church, can you just listen?
Well, that's a really important point, Jean, because as well as oversight scrutiny and holding to account, an independent member is there to provide support, advice and guidance to bring their expertise into play. So what we would ask of the executives now, use all the independent members, use that expertise, as you've said, Jean, because that's what we need to come together now as a board. Thank you, Jean. That's a really important. Thanks, Jean. Thank you. Now we're cracking on. Sorry, not having a bit of a break at the minute. And we're going to move to Catherine's thing, because this is really important. As I said earlier, this is the first time we've taken a data in its entirety like this.
So Jack, can you take us back? I need the cash letter.
Oh, the cash letter. We approve the cash letter as well? Yeah.
Thank you very much.
We approve the cash letter. In that was what I mentioned. Yeah. So I'll hand over to you now for Catherine's.
Yeah, thank you, Chair. So it's I'm grateful for doing this today. There's a lot in the report, I know, and I know colleagues will diligently read it. I'll just try and bring a bit of it to life. So just to remind us that the board approved an estate strategy in 2023, and that was after us doing an extensive amount of work on the six-factor survey at the time. That then informed the shape, I would say the shape of the 10-year programme of work for us, recognising that that would present with a menu of options, but we knew there are challenges, and we would use that based on what was available. And at that point in time, we shared the work with Welsh Government, and we were commended for being the blueprint for Wales. Describe it. So just in terms of the report reminds us of some of the key statistics that came out from that. It was a very sobering piece of work, but very informative, and it shaped the work we've done in the last few years and clearly forward. We had a backlog maintenance assessment of $1 million. 82% of that backlog maintenance was invested in Morrisons, and 75% of the estate was 30 years old. 66% of the estate was in condition C, 40, which is right, respectively categorized as below satisfactory. And the board member to be aware that excludes the private finance hospital, which is paid for administered at different levels. After that, and we've already did some detail today with concern about the elements of some of the estate as well as features. Through that work, and we had tasking finish groups at the time, the independent members, which more now into our task force. We put a primary focus on business continuity, recognizing the risks in the fabric of buildings. And to date, as we looked at one part of that work, we've replaced 50% of the Morrison de-risking that roof. And just to assure board members, as I did I thought this last, which is one of the good plotters. Move more says there's a fabrics issue, not a structural issue within the structural sense. We use that work then to develop site control plans. Control plans, those are in the document as well. Because found those useful to see those relate to the journey through the assessment and that design. Some of that thinking helped us to shape the clinical service plan at the time, and we really need to reflect on this in light of the clinical service plan fresh work that colleagues will be doing, the brief leadership will be and very helpfully part of that work as well. We're looking at our strategic replacement of services, and we're still shaping this into the right context now. The need for access to liberate the land a little more. From the Sangha junction, 46 across the land. We are progressing well with that. At some point, I believe it's next month that'll be consideration. We'll then need to work with lots of different agencies. So, see where the estate risk is, you can see where the opportunity for a clinical model, we've got a need to start that was going on actually. We use that to we touched on this earlier, and it's in there, page number about decant accommodation. In order for us to get the nuts and bolts of the environment right, we need decant accommodation. If we can move to a point where we're not just making areas safe, but developing areas, very low people decant will be key, because we work through that, we will need more wall space to get to that cognizance of our ambitions with this content. There's a dynamic or embed mathematics here that effectively decant allows us to work through the start of the year with fire, alarm calls, gases, all the things that we don't get seen, the first things that we hear about when they fall over because they're directly linked. So we've been very successful with some of that. We've used the States Funding Advisory Board money, now it's involved in the and we wrote that board to help us manage some of that risk. And we believe when the decant facilities are back up and running, I'm sure we will do that through the discussion we just had, which is incredibly helpful. And we'll be able to get back on course with some of that stuff. And we've taken a risk assessed approach, and that's set out in some detail. I appreciate putting all of those things together in one report. And what we've done is review the information and after the last year to over every stuff to do the dark test, the black star test, and then to describe how scope comes across in the report, the mitigating work and the further work to maintain the group's confidence and how we through stuff. In terms of the workforce model for the states, in particular, the capital, which is a small development team, the states team, that's it in 3 days from later, and working with the estates team to look at a change program for them as well to meet the needs of the organisation. As I mentioned on that, that's the benchmark we go through this week, which suggests there's likely organisations under the bill. From a resourcing perspective, pages 23 to 26 just give you a sense of what how much costs to run aspects of the estate, utilities, etc. But it also shows you where we've used the new sources of funding available, and we were instrumental in shaping the report in addition to 5 million to the organisation to help maintain. None of that is particularly revolutionary, it's basically keeping things going. I think the service plan needs to help us shape them. And in the document as well, there's a bit of an update on some of the live capital discussions with the people in as colleagues who drafted the chair and what we're doing for mental health, significantly central Swansea accommodation and stuff. They can only put really fit for purpose services, some of the most vulnerable communities in the city centre, but we also need to extend that fixture to care aspects of that as we do that as well. But that's a pressing matter. There's page 29, just gives us a sense of opportunity for rationalising this space in public. Remember, these are plans. These are parts of the consideration of what we're trying to look at. Better, more fit for purpose facilities where we may need to move things around to dispose of sites which are costing. We'll bring that through the next and a meeting what's government broader rather than drafting next steps which we had with the cabinet secretary. Still like there are lots of other things that want to quite a detailed report, but what I wanted to convey today was we have the detail. We know the strategic direction which will refresh. We have a very keen team to work hard on this. We're working on the risk profile basis to discuss with clear strategy. The conversations that we had there 2 years ago and track.
Thank you, Darren. Thank you too for pulling this all together. For me, it's like a reference point that we can keep updating, it can be dynamic, but it's going to play into all aspects of planning. It's a really important like baseline for us in terms of where we are. So any immediate questions for Darren?
Yeah, can I ask about the summits, small by comparison, 400,000 plus in respect of NEPA Talbot. Is that in respect of work that needs to be done now and separate from whatever happens with regards to the PFI exit, or do they run into each other?
So all of the maintenance of NEPA Talbot goes through the PFI.
That's the thing, so I wasn't actually why that figure appears with the other maintenance.
There are not all of NEPA Talbot sites. Children's unit, the accommodation block at Health Board out. The main white building that you recognise is the bit that's PFI land. That's why there's a small site rather than two.
So site in those two buildings.
The piece of work that Ian did some while ago, which you just referred to, was a template for the health groups to follow. When we had a prioritisation order, one of the things that I would like to have is the visibility of, and I'm reflecting on the visit that Rena and I made to Morriston when we were taken around the steam room. It is in this report as well, where it could, if that goes down, there's a catastrophic impact on the hospital. So I think it would be useful if we have visibility of what is catastrophic, what the on-cost looks like, and where we are in terms of mitigation. Because we can read through all of this, but that kind of template that Ian put together was really invaluable in terms of giving that transparency of where we're at. So we could have a refresh and an update on that.
A lot of words in here for the illustration.
So I've got Maria then, actually he has covered it, which goes around, we've got so much at risk and it's such troubling paper and it's so multifaceted in terms of how it impacts everything we do for infection control to how people actually get better. So I think that for me, it's that kind of very clear on the risks and what we're doing in terms of mitigations, and actually that oversight of having that flexibility in our resources, which links back to the conversation we've had forward, to be able to, if anything catastrophic actually does happen, put it right. So that's the thread that I think we need to see next.
It's a detailed question, but I'm concerned, and obviously this has been just with us. Because I'm the audit taken up with the test. I just wondered, in the context of the awards that we're going to reopen in Singleton, has it been thought that we only to make available a decant facility in Morriston? I haven't had that reassured really. Clearly that is necessary in the context of that.
That's one of the main priorities for doing it. We like to open off so we can create that space.
And we did talk about, this is coming through to getting the continuity of our plan from year end into next year, whether we would really push and have a plan for second ward, so that from the 1st of April when we get through winter, and I've said that looking at our seasons anyway, but actually having a really explicit plan that come that period around Easter, we actually take the next step, which again will be really hard, but it's what we need to do. You need to chunk it up like that.
So we can move to the recommendations then, and Darren will come back with that. Potential catastrophe. So obviously we've discussed in brief the content of the report, but we are definitely going to keep this now updated as a recommendation. So, and there's extensive information in it as we discussed that will inform our prioritisation and our planning. And the connection, the symbiosis really, between the estate assessment and our community service plan is very clear. We will be coming back on the governance around the whole approach to capital, operational, capital, case management, etc., as we discussed earlier. And earlier, as you said, there are currently risks and mitigation, and Dan will amplify those in a specific schedule. We've acknowledged and we've approved the principle of bringing back the capabilities in Alton linked to our earlier discussion. We absolutely need that. We need the right estates workforce, and we know that the personnel themselves want to see a modernisation of the workforce, so we confirm our support for that. And then obviously we will also work in progress to look at options for future funding so that we can extend as much capital as we possibly can. Is that okay? Please take our thanks back. So Tina, shall we turn to you then on organising for success, please?
Yeah, thank you. And I see this programme as a key enabler to help us on our journey to become a high-performing organisation. So some context I just wanted to talk through with the colleagues around why this programme has been designed as it has. And this is based on looking at all of the strategic risks and issues for the organisation, board papers over the last 12 months, and the key workforce metrics, hard and soft metrics. So background to it is that we've had a period of instability at the health board with a churn of senior leaders, board members, and lots of the posts being interim for a period of time. And that's, research shows that if you've got that instability at senior level, that does impact on the culture of an organisation, because there's not that consistency of what the priorities are and the delivery of those priorities. We've also come out of COVID, but also going into the financial challenges and other improvement quality challenges around maternity, mental health, had to adopt a command and control leadership to empower people, take some decisions away from them, which also impacts on how people feel in their roles. And also, we've seen through the staff survey and other metrics some variability in the leadership and management capability and capacity. With pockets of really good practice, but areas where we know from the heat map, I know where I've got areas that we need to put some support in place. The people are not getting that level of support they need from their direct line manager. So that's resulting in evidence of signs of low trust amongst our workforce. And that's, you know, the feedback we're getting around our staff engagement scores, sickness absence rates, with the outputs, the ownership that we're getting, we're seeing through the financial arena and so forth. So that's quite a lot to tackle. So I see our three-year strategy is being referenced into 3 phases. So year 1 is getting the basics right. Year 2 is the year of transformation, and year 3 is the consolidation. So we need to get the basics right before we can then transform. But we need to, obviously, the pace that we need to transform is within the next 12 months. And so the way that this programme has been designed is to help us get in the best position possible to allow us to deliver against those 3 years. And the proposal is, and I'm looking for approval for the terms of reference on these phases. So phase 1 is making sure we've got the right leadership at the top level of the organisation. So we were already undertaken the review of the executive portfolio, so really clear on accountability at the top level of the organisation, who's leading on what. I'm currently working with colleagues on the next layer down, the deputy structure. So again, we've got that line of sight for the next tier down and making sure we've got the right capability, capacity to lead on those areas of work. And also about how we explore our regional work with Haldar and making sure we've got the joint appointments where appropriate. There's a new addition to phase 1, which is referenced early in the meeting, around the delivery unit. And so when we've looked at our capacity capability around programme project management, transformation, improvement, performance and business intelligence,
it's dispersed, and we potentially got quite a lot of that capability capacity in the health board that we're not using in probably the best way. So we've now included this in phase 1 to look at setting up the delivery unit as soon as we can, looking at those component parts and making sure we bring that that together in the best ways and designed in the right way. So that's phase 1. Phase 2, we're Deb's leading on, but we're supporting, and we're about to launch the consultation with the service group TRIES, is moving away from a locality-based model. And another feedback we get from patients and staff is that there's lots of waste in the current operating model that we've got, and therefore we're proposing to move to what I call a thematic care group model. So we arrange our services into like medical and surgical, etc. But also taking that opportunity whilst doing that to regroup our specialties in the right way for the benefit of our patients, for the benefit of efficiencies and waste. And also part of that is looking at the type of leadership model that we have, whether it should be a clinically led model, which is what we want to be, a clinically led organisation, or to stick with the current operationally led model. That's what we're proposing under phase 2. We're going to start with the TRIES, and it's really important that we take time to design the new job descriptions properly, so that we get the right people in the right posts going forward. Alongside that, we'll also be supporting with the leadership development programme to make sure that if we put the people in place, that we're supporting them to have the right skills and competencies to deliver the priorities of the organisation going forward. So it's quite a tight timeline. The majority of that we're trying to get done before March, with at least agreeing those structures. There might be a delay with some of the implementation of the organisational change after March, but this is what we're trying to achieve at pace. And then phase 3 is then we'll have these number of business units as care groups. We need to make sure they're set up to succeed, and therefore what wraparound support do they need around their corporate services and wider business support. And that's what we'll be looking at as from April onwards, looking at what capacity capability we've got within the care groups, service groups already, and what we've got for our corporate services. Is it hub and spoke? Is it centralised? Is it evolved model? That might vary per function, but it's just mapping that through to make sure we're, again, as lean as we can be with our resources, but we're providing that appropriate design for those. So there's some enablers linked to this programme. I've mentioned the Leadership and Management Development Framework. It's clearly got to be a comms and engagement programme, framework alongside it to make sure we're getting the right inputs into the design of our services and structures. And the performance management and accountability framework is quite key, and we need to integrate that into this programme as well. And then to Jean's point around culture, I think having the benefit of working in different organisations in my NHS career, the ingredients of a high-performing organisation is to have a reduced number of priorities that people in the organisation gathers around. We have clear metrics on what we're going to deliver against those priorities, they're called driver metrics, that we all we monitor. We have some watch metrics, which are our safety net, to make sure things aren't falling over where they need to be. And then we have the values and behaviours of what we want from the leaders and members of staff, but we also have a single improvement methodology that empowers people close to the patient as possible to make that change. And I think, Jean, that's one of the issues that we've got to work on. We've got some pockets of good practice, and we use that methodology for the urgent emergency care change. But that's what we need to roll out as wide as we can, and that does change the culture to where you need it to be to make sure people are owning it at the right level. So hopefully I brought that to terms of reference to life. I've got in there the proposed governance structure for the programme, which will key decisions come into board, but with the exec team being the steering group, with some planning groups and sitting underneath that programme to make sure we deliver in the next 4 months at pace. So I'll stop there, Chair, and I'm happy to take any questions.
Extensive amount of work has gone into this to get us to this point. So Tina, I'm really involved in pulling it together, because
questions or?
So Tina, I liked it. I think it's a great paper and a great plan. I just wanted to challenge a little bit the phasing. And you've got phase 1 executive, phase 2 operational structure, phase 3 corporate services. So corporate services, that's the wraparound support for the organisation, but that doesn't get set in place for a year after. So
April onwards.
April 27.
Be completed by April 27.
Yeah.
Yeah.
So isn't there a risk that you won't have the support necessary? You might almost do it the other way around. Get support structures in place before you go operational.
So planning groups will work that through because there are things that we need to get in place for this April, like the budget restructuring and our ESR, electronic staff record system. There will be certain things that we have to get in place for this year. But the actual way that we provide the corporate services, we'll probably have to do that on a phased approach. So the April 27th is the stop date of when all of it be done. But we'll probably have to chunk it down. So we're starting with the delivery unit, and that will be the engine room to help drive some of this work through.
Tina, thank you for that. I got a lot out of what you just explained that wasn't in the paper, and I thought, that really complemented what we saw in front of us. But I did have questions around the paper, and I'm going to take you through each one of them. I think it's because I've been in this house for a long time. So one was the shift away from the strategic direction around centres of excellence. I wasn't clear to what extent that locality base that you've just explained moved us away from that model, and the reasons why I think that would be really helpful to understand. I think that then there is an assurance question around, we managing the risks around shifting roles and job titles and structures, that it doesn't distract away from the focus on delivery, given the huge amount of delivery that we've got in front of us. So I think assurance around that would also be welcome. And then that really granular detail and analysis of staff in position to support the proposed reduction in the pay bill, I think is really important, because at the moment, if you look at our board papers and you listen to our conversations, it's really difficult to reconcile some of the staffing shortages that we face with reduction in the bill. So I think it's just, I'm just trying to thread all of this together. I think there's gaps that, I just want some assurance on.
Yeah, so the centres of excellence, the service design will obviously be worked through phase 2, and we've got a straw man of how we think the services should be designed and clustered together. So that will be subject to wide engagement and consultation across the organisation, including, and we may want to have a development session as a board to feed into that before any decisions have been brought here. I think we're not changing the clusters of the. I don't know if you want to say a bit more about that.
The structure of the care groups almost lend themselves naturally to what sits under them. There will be a few that could be either or that we'll work through, but what we've approached as a straw man is this is what we think looks sensible, but as part of the consultation, if anybody has any hard and fast thoughts on what it looks like. So, for example, a surgical care group will have all of the surgical specialties that are naturally fit. In my head, theatres and anaesthetics sits there, but actually it could also sit in clinical support services. Yeah. My preference would be to sit in surgery, but then you've got everything in one place. But that's not a done deal. It can be something that we discuss and we talk about. So it's pretty much writes itself, but obviously there's room for negotiation and consultation.
So the question then following on from that is, are the timeframes, which is what you just had a conversation about with Steve, realistic in terms of that engagement, because there needs to be buy-in at all levels?
So this is really important because people can try and keep adding things to the programme, and I'm really clear that we've got to start somewhere and we've got to make sure we will restrict it to achieve what we're setting out to achieve. So what we'll be approving by April is that care group structure with the services that sit underneath it. So the next phase, there'll be will be then how we bring the services together and transform them. So that's what I mean about the 3 years, getting the basics right. So it's about getting the basics right and supporting those services to transform in our year 2. And so there'll be further work that's needed. We can't keep the elephant all at once. We have to make sure we've got the right agreeing what the structure should look like and then work that through. And equally, that's the same for the pay bill element, is agreeing some principles at the outset. So that, like we're saying, a maximum of, where possible, 6 tiers between the board and the member of staff. We know we've got in some areas, we've got much more of tiers, about 12 tiers, and some only 2. Just making sure we've got the right flatter structure as possible, what we're aiming for, but also reasonable and equitable spans of control. an ideal span of control be one manager to 8 direct reports. Again, that's not always possible, but using some of those principles to help how we design then the services as well, and the management that goes with it. We've currently got 4 management tiers between in the service groups, the TRIs, the divisions, directorates and specialties. Crunch that down to 3, which will help drive out some of the costs that you asked me about. So we haven't yet worked that through because we're still looking at how the services will be aligned and what that might mean, but we'll bring that information through. And obviously this design has to be result in reduction. So that will be a key factor of what we bring forward in the future. Sorry, I forgot the second question.
It was, so the second question was around that assurance that moving the pieces away will not distract from the actual delivery, because we are in a crunch point position in terms of where we need to be.
And then you do get people distracted through organisational change. And Deb, I don't know if you want to sort of comment. Yeah.
It's an inevitable risk. I think it's a risk we've got to manage. We've already talked about our informed performance management framework going forward, and we need to enhance that. We just sort of make sure we put top effort into that. It's always a risk to an OCP, as we know, people are focused on what's really important to them. That's natural. We've got to work with them to make sure we keep that focus.
So finally, Chair, if I may, on that point, can we make sure that's on our risk register with organisations?
Yes, it's a really good point. Yeah. I think the principles, the ones who decided to do it, because then sort of along the line, just so I've got Jean and Louise, and then we're going to move to Jean.
Yeah, I really like the report. I think you kept it simple. Everyone can see what you're trying to do, because it's a huge program of change, as we mentioned. So what I'd like to see coming out of that is a roadmap of change, so that we can see where the pulse review points are and we can follow that through. But I think importantly, there's a huge amount of behavioural competency work within this that I don't think we've done as an organisation yet. And for the majority of places that we're in, it's moving from that passive defensive culture into that self-actualization culture. So if you looked at Maslow's hierarchy of needs, that is a prime example of what we have to work through in tiers. So I think what you've done is given a great outline. There's a huge amount of work that we can't forget. One of the things that I didn't observe there were any showstoppers that you might have thought about. So you said where you want to go and what you want to do, and Deb's just mentioned organisational design. So perhaps it's thinking about, are there any showstoppers that if we see something starting to happen, we've got a contingency plan to move.
That's the point, Jean. I'll bring that back, and what I would work to would be called gateways, so that like a ready to go a gateway that we would then check through our steering group or exec. So I'll bring that through, and then any showstoppers that we think may arise. Okay.
Good point, Jean. We have our own gateway behavior. Yeah. Okay. We've got Anne-Louise, then I'll ask Abby to.
Thanks. It's a huge project, and people get very upset about it. And I wonder what can be put in place or has been put in place to capture what has been good about the locality-based model, so that those people who have been affected in it don't feel that you are chucking the baby out with the bathwater. And my second point, I think it's the same as Jean's, but I didn't call it a showstopper. I'm reassured because you've done it before, so you know what pain it causes right away across the board. But I wonder where this has been done successfully, what were the obstacles and shortcomings, and I think right to be Jean's showstoppers, that have been encountered, so that we know that they're flagged in advance.
Yeah, Compact have got through similar exercise, haven't they? So
and there is the structures that are in, and in Cardiff it's the same structure. However, ours a very similar structure. Our locality-based structure is probably outdated now, and if we stand alone in that space, I think in reference to what is good, I think the one thing we can't lose is keeping the hospital safe. Yeah. Okay, so that was the main output of Andrews, and that's what led to the service group structure that the previous ABNU put in place at that point. So we'll be looking at the structure to make sure we've got the right governance for who looks after the hospital itself, because services will map across different care groups. There's a risk with all different structures. Obviously, there's no perfect one, and you've just got to go with the best fit. But we know that's a real key focus for us, that we've got to make sure we've got that cover and oversight at the hospital level as well. So I think that's the main thing I would say. I wouldn't say there was anything else particularly that we would undo by doing this. I think it strengthens the overall structures that we've got to work within otherwise.
Thank you. And just following on from that, Deb, and when we discussed this first as an exec team, we were excited at the opportunity that this could provide for a number of reasons. So our patients don't travel vertically, they travel horizontally across this health board, and the locality structure has given us some degree of silo, I would say. So it follows the patient through, and these are pan health board structures. It strengthens performance and accountability opportunity as well, I think, and the shrinking of the layers is really, really important. So when I first counted here, there was 7 layers between me and a patient. That's too many. The 4-layer piece is where we should be looking at, so that we're closer to what is actually happening in the organisation. The bit about clinical leadership, we've had that discussion. We believe it should be clinically led. Clinicians are the ones that give the care. They are the ones that are closest to the patient. They are the ones that know what good looks like in their service and can make the improvements. So just real support, I think, from us collectively around this move. It will be difficult, it will be challenging, but the phase-in helps us with that. And I think we will continue to support our teams as we go through it and feedback to board.
Yeah, I'm just grateful for Tina leading this, and actually I think considering how long we've been at this, bringing this through at this point, we've made really good progress. So I think some of us feel sometimes that we put a couple of the dates back, but actually considering the work we've gone through and walking through this with the leadership teams in the service groups has been really important. I think reflecting, there is not one perfect structure. There are always interfaces. What we need to do is help the interfaces work really effectively for our patients. I think Liz's last point about silo, I've heard our description sometimes of patients travelling through our journey. You think they were in different organisations in terms of how we sometimes talk about those transitions. I think the way that we're operating through things like recovery and sustainability is in person every fortnight. We meet to try and we didn't do that before. We've been doing it for the last period, and actually we're engaging with the service groups in a very different way. What we want to get to is that we're pushing, as Michael West would say, we are delegating till it hurts, because that's what we want to really empower an organisation where people are in control of their service, can make the decisions day in, day out, plan properly. And the sweet spot about the delivery unit is the additional engine, I think you described it as an engine room, Liz, that supports that. And again, it's a sweet spot. It's tricky to get that exactly right, because you want your frontline team to have enough headroom to do the planning, to do the transformation. But actually, when they're day in, day out, really busy, that's what teams tell us all the time. They don't have enough headroom to do some of this stuff. So this provides them with headroom, and it provides them with capability and capacity. And again, we'll go and look at other places around how they've done it, because it's a combination of continuous service improvement that's sort of operationally focused, and the more strategic enabling change that we need to have in place around things like our valued digital programs. And we need to work through, is that one unit, is that two, do they work together? And we haven't quite got the solution to that, but that's one of the asks we've got of Deloitte, where they've seen this operating in other places. What is it we need to have in that? Thank you, Jan, thank you. So we move to approval then. So we ask to approve the terms of reference for organising the consent. You want to do that? And then to approve the governance structure as set out in the report. And clearly we will be regularly updated as progress goes through. Okay, so I'm going to turn to you now for the staffing level act. And committee chairs, I just want you to alert the board to anything you want the board to do in your report. Otherwise, I'll take them as read and make sense. Okay? Liz, over to you on the staffing level act.
Yeah, I'll take it as read. Obviously, it's a biannual report that comes to board. The full review that took place in November. It only covers some of our staffing areas, as you know, and we pulled out in there where it does. We've talked about the 26.9% uplift being filled and the impact that that's currently having, particularly on our variable pay. And we want to reflect in the future at 21%. That will be adopted across the whole of Wales, I believe. We've put the changes to establishments in there, minimal cost impact saving in that. And we've put the risk and assurance scores. Gerald, I'm happy to take any questions, but we meet the requirements in the Staffing Act is fundamentally what I wanted to say. Any comments?
Just wanted to pick up on the paragraph on page 324 about meeting the commission members for pre-registration nurse. That's good to see.
Yeah, up until now, we've always met our commissioners members, always.
I appreciate the ongoing issue. It's good to see that it's always been met.
And as we do for them, to all working in respect of the solution for March 26th. So we're asked to do a number of things. We're obviously going to be confident of it. We've received assurance, as you said, Liz, that we do fulfill our responsibilities and various actions. We've removed the changes that come into play, as we said, acknowledge then the completed validation of Band 2 to 3 skill set. We talked about that earlier, and then we move to approve the changes to the established following biannual review. We turn back then to the committee chair reports, and Jean, you were first with point 4. Is there anything that you want to ask of the board that you really need the board to know today?
No, Jen, I think for most of this paper we've actually covered today. So I don't know whether that's because quality and safety are one at picking up the issues, or whether we have a crystal ball and knew what was coming up on the agenda. But one of the things I like to say is that Hazel, Liz and I still have some work to do in terms of the way we present this report, because we need some metrics, etc. in here.
And Karina, on behalf of PSC, I know it's all the issues here. Is there anything that you particularly want to pick up first?
No, I think we've covered it all. It's been a major focus. It's been higher. Obviously, what we've been having is each service group along PSC one, and independent of the same issues keep coming up as we've discussed before. So, in a way, we know where they are with those.
Andrew, PPRI, please.
I think particularly the only thing to note probably is that as we go to our January meeting, there's a couple of issues there of AI that we want to pick up on as kind of policy for the organisation and doing that. And secondly, clinical coding issue, which we're keeping an eye on.
So we can I come to you then on the reporting meeting?
Yeah, again, it's very much a focus on availability, staff availability, sickness. I don't think there's anything that I want the board to do, so yeah.
Thank you very much. So Muriel, we'll move to you under section 6 of governance.
I do need to update the board for the record on the losses and special payments recorded during April 2025 to July 25. This equates to almost 692,000. And we would welcome your support in pressing the need to respond to complaints in a timely way. All the other matters have been touched on today in our agenda. We also had questions.
You've been happy to know. Thank you. And Liz, I know that you're picking up on responsiveness to complaints as part of the wider.
Absolutely, a huge amount of work ongoing, and I will bring a full update through quality and safety when we've got our plan and trajectory.
Anne-Louise, if we can move to mental health legislation, please.
Nothing from you. Thank
you very much. And Nicola, charitable funds. Nothing from me. Thank you very much. And then Hazel.
Just asking the board to approve the updates to standing orders and commercial instructions as set.
Insurance, we had a look at this in the audit committee.
and we will ask you to have time. So, we have you now, both on the standing orders and funding contributions.
I found it incredibly helpful.
Thank you. And then if we take the minutes of the meetings we've had, we've got anything on the meeting from
One from me for the main board, which I'm finalising the information that I promised to look at in terms of community, etc. So that matter that's limited, I am on the K1.
And then 25th. Is there any action now?
Yeah, we've had some updates, so I'll update the action on the
So we move on to part 7 then, which is just for noting. So we do have a new chair of the Household Partnership Forum, Helen Allender. She's not able to be with us today, and she hopefully will be with us in the January meeting. And Patty will have your last meeting of SRGA, so they'll come back to us in the new year. Thank you very much. And then we are noting 72 HIW annual report, and we do know that QSE is looking at a whole raft of recommendations from HIW report and pull them all together. So thank you very much for that. And then we've also had an annual letter in from the Public Service just to note that, and then my report at the end, everything that I've been doing since the last. So I've not had notification of any of the business, but before we move to a review of effectiveness, and Andrew has the thing, his rapporteur together. As I said at the start, this is going to be Keith's last board meeting with us, as he steps down at the end of December. And of course, Keith came onto the board in May 2020. Well, really, just in at the start of the COVID-19 pandemic. So being part of the board at that time was really difficult to in the organisation through what were unprecedented times for membership there. And in your time, served on a number of board committees, and by extensive experience you have, both from your academic and professional roles, at committee level up to the full board, and of course the regional objectives you work on Arch and more widely through the Swansea City team. This, as you know, is steeped in education, research and innovation, and strategic partnership between the health board and the university has strengthened in the last 6 years around this whole agenda. As I mentioned earlier, Keith is continuing in public service. He is the chair of Health Technology Wales and a registered member for Wales on the GMC. And as Professor of Psychiatry, as I said before, he will continue to take a keen interest in our transport programme. So, board, Keith, the whole board extends its thanks for your service, and all of us send you all of best wishes for the future.
To be part of the board. I wish you all well. It's a very challenging time. The bad news, as Janice indicated, is that I will still be bothering some of you, particularly around the Swansea-based deal. The reason I set up a visit to SUSIM today, the simulation suite, immersive simulation suite, is I think it actually embodies what we can do between the university and the health board in terms of teaching workforce organisational development, CPD, innovation, leadership and research. And I hope those of you who are able to join the tour will find it a stimulating experience. So, Valley on.
So, Andrew, then, do you want to sort of give your verdict?
That's great, thanks. Yeah. Well,
All the peanuts, I think.
yeah, no, well, I need them. It's been a bit of a challenging board, I think, to comment on. It feels to be quite an emotional up and down. It's been lovely to have a change of venue, so thank you to the university, and thank you to Hazel and Kaz and the team for making it work so, from my point of view, seamlessly. It's all worked.
I think the responsibilities for the board were set out clearly and throughout the meeting, and the gravity of that was apparent as we went through the whole agenda, and it set the context for the decisions that we made. Overall, I was struck by the amount of critical decisions and challenges that we face, and the requirement to focus on so many different areas all at the same time. But the positive is that the agenda is reflecting the reality of our situation, and we are dealing with the reality rather than the fiction of our own minds. I think is a good sign. That covers clinical services, estates, workforce, financial, etc. Chief Executive report demonstrated that where we have had sustained focus and action, we've been able to make a difference. And we see that through some of the figures on emergency, but also with maternity and the successes in the NHS board, etc. And changes in performance in emergency care. The risks reset has been helpful to scrutinise how risks are framed, and we now need to ensure that the scoring is calibrated across the organisation and there's consistency between the levels. The mental health discussion was robust and challenging, and the helpful in gaining clarity of how the different strands of activity are brought together, setting out the immediate plan, as well as considering the longer term, the clarity of timescales, meeting the medium and long-term objectives. The optometry report gives us an insight into another primary care service that needs to consider how we consider the focus on primary and community and mental health in the agenda as we go forward, particularly perhaps looking about how that's organised, so how clusters work and community by design. I am getting that. The integrated performance report has provided a whole suite of data showing the breadth of activity of the board. Further development on readability of some of the figures and how we display them would be great, as well as perhaps providing some of the summary in the summary report and moving the detail out of the reading room into the main area. Difficult discussion on finance with the lack of traction on variable pay, meaning that we need to be more adequate in solutions. Sobering discussion with the renewed determination to meet their stated financial plan. Organise for success, set out a crucial piece of work for the medium term. And finally, put a real sense captured by James of wanting to support the organisation to meet its goals and actually to open the problem as a whole board. And that was reinforced by the chair stating that we're all in this together, half clearly from me. But no, a real sense of that I felt today was that sense that we are in this together. I would reiterate what she has said, from an independent member's point of view. Sometimes it is hard to know how we can help the best, but we really do want to. So please feel that, even just that sense of support.
So I'm going to close the meeting at that point. Dr. Young, please, and Dr. Thank you all very much for your contribution. The long meeting, but we covered an awful lot of really substantial ground. Thank you.
If people are able to join Victoria, it's about a 3-minute walk from here. You can bring your stuff with you, and it's a place where you don't have to come back here. Yeah,